Welcome to Madison and the commission meeting. So seating's a little tight today, but everyone, I hope you can, if everybody will move to the middle of the aisle, we have room for everyone. Sorry, I just had to say that. Okay, and for my chairman's report, it's been a busy year, and I guess this is the end of the fiscal year, wrapping it up. So still got the calendar year, which is always a little confusing. But some of the 2025 legislative session highlights, in case you haven't heard, I'll just go over those. Tort reform, if you didn't live under a rock, and know that the governor, the speaker, and the lieutenant governor were really all on the same page on this issue, and held several meetings throughout communities throughout the state, and really researched this issue and really made it more of a global economic package. This is not their verbiage necessarily, but the way I sum it up, that evaluated the stress on businesses. And when it was presented at the Capitol by the governor, there was folks there from Waffle House, either Lowe's or Home Depot, I forget which one, various businesses throughout the state where this issue had affected their ability with their businesses. It affected hospitals and physician care in rural communities, ability to recruit. So a package was put together, I guess you would call it a bill, that ultimately worked its way through both chambers and passed. So I think that's going to have a significant impact for our hospitals and our trauma centers, both trauma centers and non-trauma centers that help support the trauma system. So I think that was a big win for us, the trauma system in Georgia. As usual, Liz and I present each year to the Senate and to the House. This year, due to scheduling issues, we weren't able to present to Ben Watson's committee, who is chair of the Health and Human Services Committee. But we were able to present to Chair Cooper's House Public and Community Health Committee, which we frequently do. And we presented our data on turning the red diamonds to black diamonds, where our quality had improved in the state over the last 7 years or so, where everyone, trauma level 1s and level 2s, to continue to receive funding, had to become designated or verified through the American College of Surgeons. And that paper has now been published in the March issue, I believe, of the Journal of Trauma. It was presented at the AAST in September of last year. And so that's been a big win for our state. We shared that data with Chair Cooper's committee, but then to show them what that looked like in real life when you improve quality and your metrics get better, what does that actually look like? We had Emily Brown from South Georgia Medical Center tell the story of what happened with survivor Captain Chris Bracewell. That was presented at, I think, our last commission meeting. You heard that story with Emily and Captain Bracewell. Very moving, very touching story. He gave that same story again so we could show our legislators what data actually looks like in real life in rural Georgia. And he said probably no fewer times that he would not have been here if it hadn't been for God, and if it hadn't been for all the trauma of people working together to save his life and putting together a system. So it was a very powerful moment. I think it really touched the legislators, and they really, a lot of them wanted pictures with him when they got done. It really did hit home to bring home the patient story. And again, this year, we were able to secure another $4 million in funding. We have that as a line item now on the budget for expansion of the trauma system. So that continues to be a success. It's not the 60 million that we need or that we asked for, but it's a start. And we're very thankful for that, and thankful now that for 2 years in a row, we've been able to receive that extra funding. And let's see what else I have here. And certainly, last but not least, I saved the best for last. Our executive director here to my left, Liz Atkins, was named president of the Society of Trauma Nurses. So she was installed and gave the presidential address just, I think, maybe 2 or 3 weeks ago it was. And I don't know if you had a chance to hear that. I could not be in attendance, but I've listened to it. It was sent to me, and we can get a copy of that if you'd like. But it was really a great address on leadership, especially nursing leadership, and how nurses can impact not only local healthcare and local trauma center care, but national care. So I would highly recommend that everyone, whether you're a nurse or not, listen to that address. It was one of the best address I've heard as a presidential address. So congratulations, Liz. We're proud of you for representing Georgia on a very big stage, as this is a national stage. And lastly, I'd like to thank our volunteers. Although there's not a lot in the room today, they're out working hard, so we appreciate that. But I want them to hear, and hopefully they're listening online and know that we appreciate them. All this work that's being done, the commission, we vote on things, we talk about things, but really all the work takes place is the grassroots efforts and with all the volunteers that have really daytime jobs. So thank you very much. So that concludes my chairman's report. And so now I need to, actually I need to establish quorum before we vote on the minutes. So I think we have quorum in the room, and then is someone online? Okay. So then can I get a motion to approve the minutes from the February meeting? All right, any discussion, corrections, concerns? All right, all those in favor? Actually, I'll just take any opposed. Hearing none, the minutes are approved. So I'll turn our meeting over to Madam President Liz Atkins.
Thank you, Dr. Ashley. Just a few things to go over with you. My full report is in your packet on page 19 and 20. And I will be having Gabby do a brief overview of the PBP and the level 1 and level 2 readiness cost survey, so you guys can sort of see where we are with respect to those two projects. And Dr. Ashley already covered the updates from the legislative session. Excitingly, we have another piece of research, if you will, or system work that has been accepted by the AAST for a poster presentation, and that is the Center project, the mapping that was presented by Nick Medrano. So Center is leading that. Since it was accepted for poster, we are putting together a manuscript for that for
You want to Center is?
Coalition for National Trauma Research.
It's a national research trauma
consortium, if you will.
consortium,
Yeah.
and it looks for funding and sets research agendas. So having them involved is really a wind under our sails or in our sails. So it's good.
Yeah, no, it's great. I look forward to more projects with them. They're really looking for more along the system line like this.
Yeah, they're a huge funding organization too, and they also are working on a national database that is more equitable for research than NTD. So they
Yep. Thank you. Great organization. And then let me just give you some highlights. Oh, actually, the abstract is included in your packet on page 22 if you want to look at that. And then if we can pull up the slides, Gabby, I will just go over the financial, the trauma center, the project that we did with in conjunction with TCAA before I turn it over to you and there's the abstract you're seeing. Okay. So if you recall, this is kind of the culmination of what we've done with our partners at TCAA. When we got together and created the 61 million ask, and we brought that forward in that sort of tiered approach of, what we could get started right now. And then that resulted in the 4 million additional that we got last year, as well as this year. One of the questions that we got from the legislators, and I think this surprised you and I, because the legislators are very savvy with respect to medical billing and all things finance with hospitals. And they were even aware of trauma activation fees. So one of the questions was, doesn't your activation fees cover enough of the trauma readiness costs? So I thought, well, we really need to go back to the drawing board and actually look at this a little bit better and figure it out, because there is actually language in the code that created the commission that says the commission is the payer of last resort. So this was a really good jumping off point for us to figure out, how are we optimizing our billing and our revenue opportunities for the trauma center? So there's a couple slides in here up front. Sorry, I can't see. It's hard for me to look up top and see that, but there's a few slides up front that's very familiar to this group. It just looks at what our progress has been over the years. So you can see huge expansion from when the commission was created to where we were in 2024. So if you keep going, Gabby, next slide. And how we've added to the number of centers over the years. And next slide. Not only, it's not just important enough to add centers, but as you all know, we've looked at what percent of critically injured patients are actually getting to the trauma centers, and significant progress once again made with respect to that, where we started at 64% and now we're at about 93%. Next slide. And then this was the most recent, I think, really great finding for us, was just based on CDC data. We knew that we had a problem with Georgians had more mortality than the rest of the country, and it was even more profound in the rural areas. But now here we are 17 years later from some of that initial data, and now we're actually 6% below or 6% better in terms of injury-related mortality rate. And next slide. So then as we looked at what does the future hold, and with that 61 million ask, you can see some of the shaded areas are where we would love to have expansion. It's probably not feasible to bring on any more level 1s or 2s. The most of the gains are going to be in the level 4 center level. I will tell you, it's even hard to bring on, and our DPH colleagues know this, it is hard to bring on even level 3s, because you have to have that surgical complement that's just really hard to get subspecialists, orthopedists, and even if you want to be a 3N in the rural areas. So this is kind of what could that look like? And next slide. So for the future, how do we grow the system without impacting funding for existing centers? So the next couple slides are familiar. You know this was the ask and how we formulated it. So the readiness cost, we took the readiness data that we already had. Next slide. We looked at what our percent of readiness costs funded. I always think of Dr. Ashley with his battle cry of 7 cents on the dollar. That's where we have been at that or less for a long time. And the next slide is what we showed was our ask, which is, could we get to 50 cents on the dollar? So that 61 million, just to refresh you, that's how we got to that. So the next slide. So as we were presenting that, this is where the question came up is, don't we make enough money on the activation fees? So just a little background of how that came up. So how we attacked this is we partnered with TCAA. So I actually presented all this just at TCAA in Vegas 2 weeks ago. And when you don't know what to do about trauma finance, you reach out to TCAA because they have a wealth of knowledge with that. So I proposed to Jen Ward, who's the president of TCAA, could we come up with some system-wide key performance indicators, financial indicators, to help us understand the degree of success or challenges that each center's having with those activation fees. I don't want to ask them to open their wallet and tell me what they're charging for activation fees. I just want to know, are you charging, number one, and are you getting paid? So she said, I love this. This is a great study. Let's see if we can look at this. So next slide. This just talks about the language that is in there. This is actually how it reads: criteria assuring that the trauma fund, which is the trauma trust fund, is the payer of last resort. And next slide is actually how we attacked it. We did a 2-part webinar series. We had 2 webinars in August and November, and we didn't target just the trauma program managers and the trauma medical directors. They know what this is all about. What we needed, or who we needed at the table, were the administrators, the revenue cycle folks, the revenue integrity folks, the managed care contracting folks, decision support, patient financial services, billing and coding, and the content focused on 3 key areas: costs, charges and the revenue codes to make sure folks actually knew what they were charging. And next slide. So we asked the centers, this was a huge ask, and I can't say how proud I am. Like, people just come out of the woodwork and say, yes, we're willing to help, we're willing to do this. I asked, could they look at either 10% of their trauma team activation responses or 20 cases at a minimum, depending on what their volume is. Because we needed a little bit of data to show what this, what the impact was. So, and then of that group that we asked to attend, all those representatives, we said, could you create a trauma PI finance? We have PI for clinical things, right? But we don't have PI to determine the viability, financial viability of our center. So next slide just shows you a snapshot of the spreadsheet that we actually asked them to complete. I plugged in the formulas so that it was really straightforward, and we picked 2 key performance indicators. One was, and this sounds really mundane, somebody at one point in time got an idea that it would be a good idea in order to capture trauma patients and who should be charged an activation response to have a type on the patient registration form under patient type, which is a type 5, which is trauma, and only trauma centers are supposed to be able to use the patient type 5 or trauma. And it's in something that's called Field Locator 14. It's just the number of the field on the patient registration tab. And then the next slide shows you the second key performance indicator was, of those patients who should have been typed 5 on that registration, did they have, what percent of those actually had the activation charge dropped? And then next slide shows you what we found. Keep going. There we go. Hard to see the shading in here, but the findings were that of the type 5, we had a lot of opportunity. So what we found out, I will go over this a little bit more in a second, but what we found out was that there is a discrepancy in terms of the application of the National Uniform Billing Code for private payers versus what Georgia Medicaid accepts. So centers were doing what they knew was actually going to get paid, which is not using the type 5 because we're not aligned with the NUBC for Georgia Medicaid. And largely that's due to a known issue with a conversion to a new software for Georgia Medicaid. So you can see that there's a lot of centers that weren't even using the type 5. So I kind of tried to highlight that red for folks who were under 10% or yellow if you were over 10, but under 90%. And then you can see the small number of folks who were consistently using the type 5. And then on the right, we looked at, of those cases, what percent actually had the code drop. So more people are actually dropping the charge for the activation, but they're not getting the type right in order to be compliant with the National Uniform Billing Code. Correct. Yes. Now, next slide. There's some caveats to that. I'm going to ask Regina to mention that. So the themes were that the type 5, which seems so simple, that's just an administrative function to click that button, type 5, had more opportunity than the actual activation charge. And it was non-specific to level. I had data from levels 1, level 2, and level 3. It was across the board. And then, as I already mentioned, it was Georgia Medicaid. There are some known issues with the software transition. I have been working with GHA. We're going to try to partner together to figure out, can we kind of figure out what's the temporary solution? Because some of the centers were told they can't use type 5 or it won't get paid. And then Regina, I think you were using type 5 and you are getting paid for some of them, or you don't know. It's hard to tell. Yeah. Yeah.
It's not Jim, you don't use it, like some of the private care kind of thing. But you're supposed to have a time in order to get the reimbursement for the activation. And they have to be free activations, like that should roll over the year for 50 minutes.
Yeah. So in summary, next slide is just, we need more education. We had 150 people on those webinars and they stayed from the start of the webinar till the very end. And they had even more questions after the webinar. And TCA has an amazing asset known as Val Wrinkle. And she's testified federally in front of Congress about some of the challenges with billing related to trauma charges. So we need to drill down a little bit more on those OFIs and the barriers and some of the action items reported in the tool. So what I didn't show you was beyond the data collection, we actually had a space for their PI finance team to identify what are their barriers and what are their action steps individually for the center, so they could have some way to know what their next steps are to increase their coding. And then we already did share the findings with the administrators committee. We're working with our hospital association on the Medicaid coding. And then the next step will be to look on the claim side to see what level of success, to the extent we can tell that, because we don't always know, but there should at least be a yes that you got something for it. So we don't know what that is, but that I think would be our indicator that we are trauma fund is the payer of last resort. So I'll wrap up with that. It was a lot of work to kind of summarize in a few slides, but. Mhm.
See a number of letters to various centers. Is that, for those centers, enrolled TCA or are they just yours?
Oh, this is our data. This is our, yeah, I can't, it'd be hard to get national data on this. This is just the centers all of our trauma centers. It's anybody who would submit data on their activation for us. There was about 17, I think a couple people submitted late, so I didn't have it in the aggregate data, but most people submitted. Yeah.
So this is sort of a
They either had a problem with, they didn't get that typed correctly, or, which was more common, or they missed the charge. Most had a charge. You can see it's a very small amount that didn't have any charge. Most people are trying to go after that charge. They may just miss that small caveat. And it's interesting, that type, that FL14, the type, is actually included in the uniform discharge data set, because we've done a lot of work looking at the uniform discharge data set. There's a lot of type 5s being classified out there in non-trauma centers. So somehow we gotta partner with whoever that is to kind of clean that up, because you're only supposed to use the type 5. Yes, that's what triggered the audit. Yes, the OIG audit. Federally, not statewide. That's a federal thing to look at. Yeah.
which we're still waiting to hear, if y'all know here what that is, but the OIG has done maybe a year or 2 year long study of collecting data, looking at this. And they were supposed to release their recommendations or findings months ago. Months ago, and that keeps getting pushed back, and now it's pushed back to either May or June. We're in May, so it's probably gonna get pushed back again. So TCAA, Trauma Centers Association of America, is monitoring that for us because it'll affect our trauma centers. So with the change in administration, and there's been change at the people actually doing the audit, if I can say that. There's been change in leadership there, so nobody really knows what's going to happen at the federal level, if that study is just going to go away, if it's going to pop up with some findings. We really don't know, but as soon as we know, we'll let the commission know and the state obviously know.
Yeah, this just is a report that they're at the OIG. There's gonna be penalties. So
You push your button, Dr. Dunn.
He's pushed, you just gotta,
Is it okay?
we have to talk into it, I guess.
So it certainly said that we significant penalties. If you're one set of have a chart or maybe that's a lot.
So this is our opportunity, since the OIG is looking at it, that people, not so much to, maybe get funding or get funding for their activation fee, but also to not have penalties. So this is a good time that should help you get people to the table for education to stay out of trouble. So I think there's a carrot and a stick here with this study to help our trauma centers and non-trauma centers. If they're using it, if they're putting a 5 on there, I mean, I would not want to be in their shoes, with the OIG I mean, those fines will be incredibly high, over a simple, putting the wrong number in the wrong box, although they're trying to get money when they can't bill for activation fees if they're not a trauma center.
I think people just don't understand what the definitions are. And I'm
Yeah,
not sure
there's a lot of
people are really
confusion.
clear.
A
Yeah,
lot of
yeah.
confusion.
Can't do this and it can't. Have to be reactivating, oh wait, but that can bill post that.
Pre-notification. Yeah.
It's code, but we're not in this, for the application, when can you use it, and when can you not use it, so it's real, it's very.
So when, how close, or what's the next step? This has been a tremendous amount of work. I want to commend you for it. But this is really cutting edge work, and then bringing in the national organization to help you. So kudos to that. So, where are we with the next phase of like being able to answer that legislator's question? How much do the activation fees go? Because and I have to admit, I don't really know in my own shop, which I'm going to go back and ask some questions and see if I can figure that out. And I'm not sure I can. If you know anything about a hospital accounting, you know, it's
Murky.
strange, it's murky. How close are we to knowing what the trauma centers are getting with activation fees? Because it's been my assumption that we bill it, but we don't get paid for a plethora of reasons.
Yeah, that's a great question. And I just want to say real quick, I couldn't do any of this without the willingness of all the centers who I ask them, I flog out a spreadsheet and they flog it right back to me. Sometimes I'm just amazed by how willing everybody, I mean, we ask for this. Oh, by the way, we need a readiness cost survey. Oh, and you need your G-QUIP matrix, like all the stuff we throw out at them. But the fact that they're so willing is what makes us one of the highest performing systems, I think, in the country, is that there's no lack of willingness out there. So thank you to everybody who submitted. And then the next thing is, I think we're gonna have to go back with TCAA because of some of the type 5s missing, which probably we can even not look. We can probably just look on the claims side of the activation, whether you coded it correctly or not. We could just try to do that deep dive now that people are getting more accustomed to looking at it. But if you want to comment, looking on the claims side is a little different than just looking to see if the type 5 was captured or the claim was dropped.
One of the challenges we still have that.
Can you use your mic? Sorry. There you go.
Okay. One of the challenges I think we still have is the fact that trauma program folks and billing folks we're getting better at understanding each other's language. We're doing like the Rosetta Stone of learning each other's language with TCAA helping. Valerie's good at bridging the gap and being a translator. But I think we have a little bit more work to do with the billing side of our trauma centers and TCAA. To educate them on what's correct, what's appropriate, and still how to use the codes, because I'll still run into some issues about when to add the G code, when not, when you can add the 68X revenue code, when you can't, that kind of thing. I think we're probably not quite at the point of really getting a good handle on what's being reimbursed. Once we break through and we start dialoguing back and forth with language we both understand, then we can dig into that next piece. We are being paid for some. Obviously, when your patient gets admitted, it gets rolled up into a DRG and you get your lump sum and so forth. So you can't see direct line item payment for your activation fee at X dollars that they set it at. But like Liz said, you can see whether it was paid or denied or not. You can we want to look at denial rates. If it's being denied, why is it being denied? It's usually documentation issues. Can we improve documentation? So I think that's kind of the next piece. What are we seeing? Who's getting reimbursed and why? Who's not? And what can we do to improve it? Just like we did for VAP. Oh, your VAP rate's high. Why is your VAP rate high? We'll adopt what you're doing and it'll come down. Your reimbursement rate is good. What are you doing different than what I'm doing so that I can maximize my reimbursement rate? Once we kind of get to that point, then we can rest assured and show proof to the legislators that our hospitals are maximizing the opportunity for reimbursement.
I think it's a little bit different. Standpoint, y'all don't have a monthly audit feedback in y'all's hospital systems of, you
Some
don't.
people have a fee. Some people have a finance worker for sure, yeah, it was like.
Uh.
Perfect, but something, my hospital was not, so I didn't know I did that, so behind the scene, behind the curtain, you know, ignoring the person behind the curtain.
We're breaking that down, though. I think one of the biggest things, and it's something you're probably very familiar with, is we're getting some confusion over, particularly in the emergency department, a pro fee critical care charge and a hospital facility critical care charge. And what that documentation looks like. And sometimes a facility will meet the 30 minutes of critical care before the pro fee does, because you have to back out things. And we're getting some pushback on, well, we can't bill that. Well, yeah, you can if the patient is deemed and documented as critical and your facility is providing that constant monitoring kind of thing. So,
Okay.
but not everybody has
We
those.
literally have a drill down, every physician, I get a feedback that tells me like. you-
But that's for your
you
pro
could-
fees, correct?
You could have gotten this for your splint, but you didn't document it correctly, et cetera, but y'all don't, yeah. Well, it's great and it's not. I just assumed that everybody got that in all systems, but assumption, you know what they say about assumption?
Yes.
So I have one question, comment. Don't know a lot about it, but if non-trauma centers are billing this code at some point, would that not also be an enticement for them to come in? If coming into the trauma network, being designated would then give them the ability to bill that code? And I don't know if it's a substantial reimbursement or low, but I just thought this could be an opportunity as you're trying to track more centers into it. If there are non-designated centers that are maybe mistakenly billing this code, but it may be an insignificant.
Oh, they're not, I don't know if they're dropping the code for the charge. What they're using is the type 5. So they're typing it as trauma, but I don't have a sight line into, like I do with our trauma centers, to say, are you dropping the code? But to Regina's point, the OIG audit will show if they're using the type 5 and they have dropped a charge for an activation fee, but they are not a trauma center level. How would they do that? Because they'd have to be 681 or 2 or 3 or 4 based on what? Oh, that's right. Just like you do for non-pre-arrival. Yeah. Mhm. Yeah. You just pick a level, whatever you want to be that day.
Once you get into the point where you found out just about all that answer, so let's talk to this and what we can do on the EMS side. In regards to,
Pre-arrival notification would be, yeah.
several questions in regards to that. It's
Mhm.
not in place right now to try to dig that,
Yeah.
but when y'all do that
Mhm.
is let us come talk or whatever, so we can determine some education without their.
I will say, if this provides you with some just generic comfort, most of the non-pre-arrival notification are walk-ins. They're not that they weren't called. It's not really globally, yeah. Mhm.
But I think there's an opportunity in the future.
At the people online, sorry. For EMS, because we would love to capture, we need to capture more, the decision making based on the field triage criteria. What field triage criteria was used to make the decision to take the patient to this particular facility? Because that's not something we're capturing consistently. And we would love to capture that. You guys probably have that on your trip sheets, and then we have the ability to capture that in the registry, so we can start grouping some of that together.
I think that the commission, we're gonna have to think through how we're gonna present, how we're gonna answer the rest of this, but. Because I think what they're asking is, of the total cost that you refer to the trauma center, how much offset is the activation? And there's, it's just, that's a complicated question. And I know, we're not gonna be the actual numbers of the trauma center, we may get percentages. But, and we're gonna think through how we answer that question. That's a difficult question.
What I think we're gonna be able to answer to the legislators when we keep pushing for the ask is that we have maximized trauma centers' ability to bill and reimburse trauma activation fees. And then we're still right, and then they're still submitting the deficit of care. So, you know, we're auditing them, they're using the type 5, they're putting the charges in. We can't control payer payments. You know, if the state wants Medicaid to pay more money to trauma centers for trauma care, they can look at that. But I think that's where we can address the question to say as a commission, we've maximized that, but they're still providing there's still a deficit between cost and reimbursement without an actual number.
It would be nice to answer the guy's question. It's a sensitive question because trauma centers don't want to just say how much money, like they probably don't want to say, well, I charge X thousands of dollars for my activation fee and I get paid X thousands of dollars or hundreds of dollars for my activation fee. So that's sort of proprietary. They don't want to just show their accounting. Sure, HCA doesn't, and Wellstar and Atrium. I'm sure they don't want to put that out there, but that's what the legislator is asking. He's like, how much money are you bringing in from your activation fees? And so you're telling us 7 cents on the dollar, which is true. I mean, if you do all the analysis, we got data out the wazoo. But I don't have that piece to know exactly how much activation fees they're getting. So I can't answer that question. So I understand the center's not wanting to just say some things in accounting, but we're going to have to come up with something at some point when we build camaraderie with the different institutions and say, and I don't know how you ask the question, you know, we really don't care what you're billing. What we care is how much you're bringing in from your activation fees. And maybe it's a percentage. Maybe they would say, okay, it only offsets 3%. It would get us to 10 cents on the dollar with activation fees. And then we could say as a commission in a big room, well, we're still short. So we have to get to some kind of data for those legislators that keep asking that question. You see what I'm saying? But it's a complicated ask.
The problem is, I don't think that number exists because you don't get paid that way. Right?
I know, that's what I meant by
So
hospitals.
it's kind of
It
like.
goes into a bucket. You don't know what's
Well,
what.
Not even that. So when you submit your payment, it's a lumped payment for reimbursement right? So even though it's listed individually for your chart, we can look at what facilities are charging on average. But the reimbursement is a lump reimbursement. So say, for example, I charge $30,000 for my highest level of activation. I can't see based on a reimbursement, how much of that 30,000 was paid for that particular line. So that's why it's going to be hard to give them a dollar figure. Now, they can all come up with, you know, average cost per case for a particular grouping of, say, DRGs, or if we want to take all patients who are type 5s and then come up with what percentage of reimbursements do facilities get based on charges, we could probably come up with something similar for that. But that's a much
Like a
more global number, right? So I
Only
would-
reimbursement
Yeah.
with
that's-
activation fees in there. We just need to tell them the activation fees are in there.
Yeah, I'm sure that's still gonna,
And we're
Fall
still
short.
short, as long as we show all our revenue.
because what you'll add is not only will you add the charges for the care, but we need to add the readiness charges on top of it. So it's probably even gonna be less than 7 cents on the dollar if you add it all together.
I'll pass it over to Gabby so she can give a hopefully brief update on the PBP, and our PBP will come up in the finance report, I believe, and readiness.
Good morning. I'm going to go over the PBP. One important thing to note is that all the PBP has been stakeholder reviewed. So the trauma and burn PBP has been presented during all the committee meetings that happened in January and February. We also had a 2-week open comment period for the trauma centers and burn centers. We also have contractors with PBP. We have the RTAC coordinators. There's one per region. Dr. Tim Boone, who's over the AVLS program, Georgia Trauma Foundation. And again, you see 31 trauma centers and 2 burn centers. We also have GEMSA, but they're off cadence contract, so their PBP is pending. You'll see the RTAC coordinators PBP. It is the same as last year, so they have quarterly RTAC reports, participation in their monthly meetings, attendance at the EMS Regional Council, and a new PBP is their one-on-one with Crystal Shellnut. So they have 8% at risk. Dr. Boone has the same PBP as last year. It's the timely submission of the quarterly reports for the EMS committee. He also has a PBP tied to his equipment replacement, and that's time bound by January 1st, 2026. Georgia Trauma Foundation has PBP timely submission of their quarterly reports, which she reviews here at the commission meetings, and then quarterly invoices. And that is for the contractor PBP. Liz, did you want to do the motion for the contractors before we get to the trauma center, burn center?
It's going to come as part of the finance committee
Okay.
motion. So
I'll just
you don't-
read it.
yeah, you're just giving them a little high level.
All right, trauma and burn center is a little bit more intensive. So we had a call for a work group. We had 8 stakeholders. Again, we had the GTC committee review the PBP. We had an open comment period, and then the finance committee did approve the proposed PBP for the trauma and burn centers as well as the contractors. The open comment period, we received 21 submissions. 12 submissions had no comment, 9 submissions had feedback, and we did identify 8 PBP for clarification or work group recommendations, and that is included in your packet. Some big changes that happened with the trauma center burn PBP is that we transitioned it to look more like MT-QIP. So we added tiers, and there is a reformat. So you'll see it reformatted by role of the trauma center. And I did add that to your packets on the side. So you'll see that on your tables. So the tiered example is the appointed senior executive level 1. You'll see that they have tiers for participation in the meetings. So the more meetings that they attend, the higher percentage they can achieve. If they do minimal participation, then they can receive up to 0.5, and it goes up to 2%. In some meetings, we have to keep it a yes or no because it's just one requirement. Some additions we added this year is time to first dose VTE prophylaxis, time to surgical care in geriatric patients for isolated hip fractures. And that is for levels 1, 2, and 3 in burn for the time to first dose VTE prophylaxis, and then levels 1, 2, and 3 for the time to surgical repair. Level 4 centers, we added a requirement for trauma registry professional continuing education. And then one addition from the open comment feedback period is that level 3s wanted to add registrar participation in national TQIP. So we did that, make that virtual participation with in-person encouraged. We removed a lot of criteria that was redundant as it was a GTC contract requirement, or it was already required by the ACS for verification. And then we did remove level 4 requirement for yearly NTDS data submission. A lot of criteria edits went forth with the reformat and adding the tiers. We did add a lot of clarification on there, so no major edits, just to clarify. A lot of percentage adjustments because of the tiers, so you'll see that throughout. And then one thing to note is the PBP cadence update is starting in FY 2026. We will track the PBP within the fiscal year, and your FY score will impact the second subsequent fiscal year. And here's kind of the overview. Previously, we tracked it calendar year and fiscal year for PBP. The scorecard was due in April. And then, for example, your FY 26 would impact your FY 27 funding. Future state, we're just going to be tracking fiscal year. The scorecard is going to be due in August. And your FY 26 score would impact your FY 28 PBP funding. Some future considerations is exploring virtual TQIP attendance for level 4 centers. We would like to open the discussion with the TMD committee regarding the TMD COT membership, developing statewide data abstractor education initiatives, and then developing supplemental reference documents for the PBP criteria. And thank you to our work members. You'll see there we had a good representation from all centers, and we couldn't do this without them. And that's all I have for PBP.
This is under the finance section of your packet. Sorry, it's on around page 140, 148, what starts the PBP. Yeah, sorry about that. And there's also a supplemental handout that shows the tiers of the PBP for ease.
I'd like to congratulate everybody that's worked on this. This is really impressive. And the PBP has really come a long way from the first days of just fill out the form and there was 3 criteria. I mean, and we started that way very gently to let centers learn how to do this. And it's just very rewarding for me to see it come to this level and now actually have some clinical metrics, which was the, the goal, but it's taken us years to get there, but in a slow way, so people didn't feel threatened. So I'd like to thank all the centers and everybody that's worked on this. So this is really nice.
Thanks to Gabby for herding all of them online. And then the readiness, do you have a?
I
Over.
don't have a reference in the packet. I think we just included PBP, but I
Okay.
can review I don't think it'll let me review the resource hub. But just briefly, we sent out the readiness cost survey in April. And we did an introduction webinar. And we've had some questions come up since then. We do a monthly webinar drop-in for the trauma centers to support them through the September 30th due date. And we have a resource hub on the trauma.ga.gov website, which has all the details, the webinar recordings, the FAQs, the timeline, everything's there for them. So we hope we will get that September 30th deadline with the submissions.
I'm so sad Gabby can't share the resource hub because it is amazing. It's a full page dedicated to just resources for completing your readiness cost survey. It's the survey, it's a compilation of all on the webinars. Any question that comes in, we expand the FAQs. It's got our readiness cost papers, so folks can look at what we've actually done with the data. It's amazing. So it's a one-stop shop for anybody who's got questions. We've already got some great questions that have come in that we've been able to clarify. Translating all this, the last iteration from the Orange Book to the Gray Book has not been easy, mostly because the Gray Book is so streamlined in what they don't give you a lot of additional context like the Orange Book did. So we've had to really go back and figure out, there's some things that are just really vague, like being compliant with EMSC or the PEDS readiness project criteria. So what does that mean? Well, I happen to be sitting at TCAA and they said, oh, we asked for funds to buy pediatric gowns, badge buddies, like things like that. So now we have some contextual things that we can actually quantify costs for some of the harder to quantify things, but, and then the ever pervasive dedicated operating room. And that's been a little challenging. But thank you, Gabby, for getting herding.
And we do have, I want to recognize the work group members for the readiness cost survey. So we have
Yes.
Regina, Liz, Kelly Vaughn, Whitney Williamson, and Tracy Johns, as well as Jessica Story from Warren A. Britt. And so they've been tremendous help.
Jessica's been a huge asset since she's been with us since the beginning of this, so.
So I just want to make sure I understand it right with the 2 things that are clinical, I forget how it was worded, but time, I think, to DVT prophylaxis and certain patient population. Yeah. I'm sorry, my bad. Sorry, did I jumped back? I'm doing like. No, never mind. I'll go offline with that. I'll table my comment. Huh? Okay. Huh? No, I didn't have a concern. I think that's reasonable where we're going. We've been very methodical, so I mean that. But that's it. No, never mind.
Concludes my report, and we can pass it off to our Georgia Quality Improvement Program. We've moved GQIP and the RTACs up under commission since they technically are all commission programs, so we're doing all the programmatic stuff first.
Good morning. I'll be quick. Just a little update on our work groups. The VT work group, met the first of the month. Dr. Galloway, had some takeaways from his presentation at the, winter meeting, the GQuIP meeting that he brought back to the group, from that. And, time to care's kind of been a little bit on hold. We may look at restructuring that a little bit with our new leadership from that. I know the, big item in the room is the benchmarking, the risk adjustment on the Arbormetrics site. I am happy to say, hopefully in the next 2 weeks, it will be live. It is in what we call the user acceptance testing site, so we can see it. So Dr. Smith, Dr. Ayoung-Chi, and myself can see it. And we had a productive meeting with Arbormetrics yesterday to kind of finalize. Really, it's just kind of labeling what's there in the dashboard, making sure that Dr. Ayoung-Chi understands what we're looking at so we can help others understand what they are looking at, and that it's labeled appropriately. But it has been modeled and it is live in reports. We've just got to make sure before we open it up to everybody else that it is readable and understandable in the best way possible. So it has been challenging and a long process. We've had a lot of turnover within our project team and Arbormetrics. We're on our third data scientist, so it's made it a little bit longer with that. Also, they have our VTE prophylaxis process and outcome measure that will begin to build as soon as we get the risk adjustment live. So they're already looking at that to provide us a timeline when that will go live. My hope is that should be in the fall. So it will coincide nicely with the PVP that centers will be able to look at the dashboard and Arbormetrics to see where they're at on a regular basis. With that, that was our goal with that. We are still working with the attorney on our policies, especially with the PSO. We completed the finalization of the data protection policy, so that was a big one for us. We've got a GQuIP and TMD call next week, next Tuesday, and then our summer meeting is finalized. We'll be meeting in August 22nd at the Macon Marriott City Center. That will be a smaller meeting. We'll really focus on the data with that. Our new leadership team, obviously they hit the ground running with our February meeting. It was kind of like, welcome, and here you go. So, but they really did a great job trying to come together quickly on that and run that meeting. We've been meeting frequently every 2 weeks with Dr. Todd, Dr. Smith, and Dr. Ayoung-Chi and myself to work on our next steps for GQuIP. We also have a half workday leadership retreat, if you want to call it, coming up in June, where we will work with Dr. Sharma from the NSQIP side, as well as all the trauma side leadership to kind of do some strategic planning from that standpoint. I did include, and we also have filled our contract help position for our PRS specialist to help with GQuIP, and I'm very excited to be having Sarah Parker join us part-time, doing a few hours a month helping with GQuIP. She will be invaluable to help move the data forward. She knows the data very, very well and running reports. So that will be helpful. She will start probably in the next couple of weeks. We're just actually waiting for DPH to secure emails and computer for her because having access to our platforms, we want to make sure that access is secure. The NSQIP collaborative you do have in your packet. They had their winter meeting in March, and it was an excellent meeting. Dr. Galloway wrote a great write-up summary of the meeting, which I included in your packet, and some photos that he put together of that. It was well attended by every center that was represented in NSQIP, and we do have one new center, Northeast Georgia, has joined the NSQIP collaborative, so it is grown a little bit. So we actually had members from the American College of Surgeons come and talk about the EGS verification program as well as the geriatric verification program at that meeting. So And also in your packet is their required summary of their publications, presentations, and ongoing projects from the past year. Luke will be leaving us in June. He was only a 1-year research fellow, but we do have another fellow from Emory in the pipeline. Dr. Hillary Jessup will be joining us in July. So Luke is already starting to hand off. She's starting to join our meetings. So hopefully that will be a smooth transition. Yes, sir.
Because that's a lot of report. Even when the, risk adjustment model gets set, if we decide to go in a different direction from our, do we lose all that?
Well, that's a great question, and Dr. She may be able to answer that a little bit better, because she does have some of the Excel spreadsheets and stuff that they've worked on from that standpoint. So, I mean, obviously we would lose the site. We're right at a 1.5 year mark where we're at with the platform this month. So. Correct. And we did all receive an email yesterday that TQIP is going live with a real-time data submission starting in 2026, which I think was a little surprised that it was going to be that quick. And, you know, I'm sure there'll be more information coming down the pipe. We knew that they were going to move to more real-time ability to see data. And that may change the game as well a little bit for us. So.
Thank you, Gina. We'll move into the RTAC report with Crystal Shelnut. Crystal, welcome.
This really feels like the hot seat. Just gotta get that part out of the way. Right, I can only imagine. Intimidating group.
We checked our knives and guns at the door, so you are totally safe. It's a safe environment. Cone of safety.
All right, a couple of updates for you. So first, the Stop the Bleed program. We've received all the kits from the last application period. The coordinators are finishing up the distribution of that and looking forward to the next application that will open in June. We've had a lot of calls and emails and excitement around the next application period, so I do expect it to be a big one. One of the changes in the kits that I believe we discussed at the last meeting, but all new kits shipped from North American Rescue will include the QR code that we discussed to report successful use of the kit. That links to our website under the Stop the Bleed tab, very top. It has a link that it goes to Smartsheet so that we can track who's using these and where. You don't have to go through the QR code. The coordinators are going to be making people aware that this exists on the website for all the kits that we already do have deployed so that we can start tracking that a little bit better.
The application for get those out, where is that money coming from?
It is.
Okay, do we have a fund set aside for relief programs?
Yeah, I believe we have a set budget for the next fiscal year for those applications. 250,000 was approved. And it might be to a point where we have to start discussing what does a competitive application look like? Do we need to start prioritizing the applications that come in? I think this next period will really give us a lot more information about how many applications are going to come in across the various regions. We did have a little bit of a backlog in Region 9 with kit distribution. Our new RTAC coordinator, Coy Tippins, has completed about 60% of the backlog of trainings and kit distributions in Region 9. So we're very proud of that accomplishment as well. Let's see. So the next, as far as RTAC leadership, I did introduce Coy last time that he's now in that role and starting to get his footing. We finally have an RTAC, a Region 9 committee. A new chair was appointed within the last couple of weeks. Crystal Hensler is an EMS director in Liberty County. I've had several conversations with her. She's excited to move forward. And we have our first meeting on the books June 18th for the Region 9 RTAC, and I believe it's been several years since we've had a formal meeting there, so we're looking forward to that. And then the two additional things for my update. One, last meeting I went through just a quick summary, kind of top highlight from each of the coordinators, so I'd like to do that again. So first, Region 1, Scott Stevens has launched a new burn care course in partnership with Grady. This is directly addressing an EMS training gap that was identified by his educational needs assessment. I believe he's got 6 courses scheduled over the next couple of months working with Grady. Region 2, Kyle Gibson. Kyle has started, which is going to be replicated, I believe, across the state, but a pop-up education series that they're doing. There were specific skills identified in the educational needs assessment, needle decompression, difficult airway management. Well, they're doing pop-up skill stations at the ER. So in the ambulance bay, they've got some task trainers set up, and their trauma team is coming to help them work through some of those skills. Takes about 5 minutes, but it's a real opportunity to kind of meet the medics where they are. Northeast Georgia Medical Center is where he was doing those. Region 3, Danielle Johnson. This is also in response to the educational needs assessment. Her next meeting next Thursday, instead of being a traditional RTAC meeting, they're actually doing an MCI tabletop. That was identified as a top priority for their region. So they're going to bring together the regional trauma plan, the EMS individual agency MCI protocols, along with the hospital. So really excited about that opportunity. Region 4, Jay Connolly, they have expanded their Stop the Bleed outreach through a partnership with HOSA. They had hundreds of kids that were trained in bleeding control techniques, and he plans to also implement this Region 2 pop-up skills protocol. Region 5, Crystal Smith, they hosted a pediatric trauma symposium and a sim day. They brought in 30 child actors for the training. And this included a scenario that was inspired by a trauma survivor who was present that day. So a really great training opportunity, again, around 120 participants in it. Farrah Parker Region 6, they trained 120 high school students in bleeding control and have partnered recently with another state agency to bring a forensic fire, death, and burn care course. This is going to be across Georgia, is my understanding. They're in the early planning stages of that, and they're also expanding their RTAC leadership. Brian Doherty in Region 7 has conducted a multi-agency MCI drill with EMS hospitals and emergency managers. This is again aligned with their educational needs assessment as a top priority for training. We've discussed Region 9, their June 18th meeting is a big highlight for them. And then in Region 10, Kristen Spires, they've expanded their pre-hospital blood program. A newly participating service has already transfused twice plasma in the field, and that was within the first 2 weeks of them having access to the product. So really celebrating that, and that now makes 40% of the counties in Region 10 that have access to blood products pre-hospitally. So really big celebration there. So those are the updates.
Tell me again, Region 10, where is that?
The Athens area. You're in it. Welcome.
I'm in it. Well, it's good to know. I've got some plasma. Wait, so the Athens, okay, Region 10 is a little hard for me to keep my eye on there. Remember where it is on the map, but so you said 40% of the counties?
Yeah, we only have 10
access to
counties,
plasma?
but that's 4 counties that have access to, 2 of those are through Northeast Georgia's program, and 2 are through Piedmont Athens that provides
Wow.
product.
I mean, that's 40%. I mean,
a big deal.
40%, even 4 of 10. I mean, that's huge.
Yeah.
I
And
mean, that's big.
it's my understanding she's got 2 additional counties that are in progress, working. Yes, sir. And Athens, the Athens area ambulance service has discussed interest in coming on board, and their medical director also serves as the RTAC chair. So I think we'll get some progress on that one as well.
So have the issues now, like if we get a question, like a random question from EMS or from a hospital or from a citizen said, well, the paramedics can't give blood now in the field, it's outside scope of practice or whatever. I mean, it sounds like people have worked that out. So is there a template now for a community a county to say, this is how we do it in a hospital, and if there is, could I see it? Because I think I need it. So it's a selfish question.
It absolutely. And this is something that the RTAC coordinators are working on collaboratively to ensure that we have consistency across the regions, but also to serve as a central repository. When services say, hey, we want to offer blood in our community, we want them to come to the RTACs. We want them to participate in our program so that we're using the same protocols and so that we can make it easier, right? Here's the training that you need to do. Here's a protocol. Let's make this as simple as possible to integrate into your
So the
service.
barriers have been worked out with the appropriate folks that this is not like, it can't, so we don't have to hear that anymore. It can't be done.
It can be done.
It can be done. It's
You have to
worked
have
out.
willing
Okay.
partners.
All right. I got you.
What level of training do you need to be able to give?
It is a paramedic. It's a paramedic that has, that's correct. And many services just kind of across the state that are working on this program, if they do run BLS ambulances, the product is on a ALS, quick response vehicle chase car type response. And I think that that's a really good model. I don't know that blood on every ambulance across the state is a reality or even what we need, but we do need it available in every community. And one of the unique things in the service, the most recent service to come online with Region 10 is they're not immediately in the county where our trauma center is, but they're actually serving the 3 counties on the other side of them with blood response as well. So those counties have to pass through Madison County to get to the hospital. Well, this QRV is going to be willing to meet those other services. So not only is it one county that has access to the product, but it's actually a much larger catchment area. I think we can work on that. Yeah, absolutely. And that's a great idea.
The reserves.
And
Yeah, I'd love to see the counties and just on the 159 county map, if you just color it in red or purple or blue, just a piece of paper. I'd love to just see it. Just
Gotta be
so I
red,
could see
right.
it. Yeah, red. Let's make it red.
now,
Yeah. Okay.
I think another key component to this too is a partnership with a hospital to help with the blood, maybe being able to put the blood back in it so it doesn't get wasted or whatever. So it can be done as a standalone, but I think it sounds like a key component of this is a partnership between the EMS agency and a hospital to make sure we're not, we don't have blood expiring. So
it has to be, and that's how we can maintain the costs as well. If EMS was having to incur the cost of blood, whether they use the product or not, that makes it out of reach for a lot of services. So ensuring that it can be cycled back into the blood bank is important. It's also the biggest logistical concern because now we have to have constant temperature monitoring that can be monitored by the blood banks. It's great and it's what we need to do, but it certainly causes another layer of struggle. That's my understanding. Yes, sir.
Can you guys get that fixed?
Right.
My EMS colleagues here? That'll be fine. Huh? I know, I'm being funny. I know it, but that's what I'm asking. Can you all go to the legislators or insurance commissioner and that, because you all need to, right now, from what I understand, the hospitals are funding it, passing it through EMS, rotating blood out. And I'm glad with that. Our patients are getting blood. But that's probably at some point, some administrator, somebody, there may be a hiccup in the road. So we need to get government to pay for it, or you all should be able to bill for it where you can bill for your blood and then, and still have the hospitals help rotate blood out. You're always going to need that because if you don't use it, you don't want to waste it, we'll use it. But you should be able to be paid for that.
pretty particular. Yeah, but I think that, again, this is an opportunity for the RTACs to have a lot of leadership across the region in establishing those relationships with the hospitals that are willing participants. And for the Region 10 project, they were willing to partner through the RTAC because every service is going to use the same protocols, the same technology. They're learning one system and not 5. So that was a benefit. All right, and then the next part of my report, and I'll be brief, is we've completed, the RTAC coordinators has officially completed the educational needs assessment report. That's in front of you. It starts on page 56 in your packets. In the research that I've done, I believe that this is one of the most comprehensive EMS educational needs assessments that's certainly been conducted in the state and many places across the country. So there's a lot of kind of takeaways that we can use from this assessment. And one thing that I'd like to highlight before we get into the details is that your RTAC coordinators are already making changes to what they're doing based on the things that we learned this year from the assessment. So some kind of high level takeaways we asked were, what type of education content and delivery do the medics want? And we know from their responses, they desperately want education. They need it to be close to them. They need it to be affordable. Those were consistent takeaways. So let's see, if you look on page 6, I think it's 6 in the report, which is the kind of the center of the page. The last graph on that, I think, is a really significant one. And this talks about the years or the average amount of experience of the people who responded to the survey. 68% had greater than 5 years experience in the profession. So these are not new people. These are not new medics in the field. And some of the things that they're still requesting additional training on are significant. Advanced airway management, needle decompression, trauma resuscitation, things that maybe we've taken for granted as being kind of fundamental and foundational skills of the profession. They're still requesting additional support on. And so one of the things that I'd like for us to do, and we're asking for the RTAC coordinators, is smaller classes more frequently. Medics do not want online education. Only 37% of the respondents said that that was a valuable access for education for them. Now, near 60% said that it was absolutely necessary for recertification purposes. So we've got a balance that we have to find there. But I just wanted it noted that these are the experienced people in our profession that are speaking to some of these skills. On page 7, the next page, it discusses the barriers that most of our medics are facing. So distance and travel, that's one of the most significant ones. And then the time constraints. We know many of our providers are working multiple jobs. So finding things like the pop-up skills on in the ambulance bay, I think that that's a really creative solution to, they might not be able to make an additional course somewhere, but they're going to be at the hospital already. So a good opportunity to catch them and do some training. The most requested skills, that's on page 9. So trauma resuscitation, 47% of the medics that responded said they needed additional training on trauma resuscitation. Pretty significant amount. Needle decompression, mass casualty, and tourniquet application were also in the top list of skills that they wanted training for. And so again, it's based on this list that your RTAC coordinators are trying to develop specific training around it, make sure that we have increased access to it, and that we can support our services. Another significant finding from the report was that in-house training is preferred to anything else. Now, maybe that's because it's on shift and they don't have to go anywhere else. Okay, maybe that's one reason. It probably also speaks to the time constraints, but some of our regions are putting together not just training for the medics, but train the trainer courses. So send us your training officers. Let's do training with the trauma team and with the coordinators, and then they can take that back to their services to do in-house training. But it's with consistent messaging and research and that's coming from the RTAC. So another significant thing we'll see more of them doing. On page 12, so we asked the EMS leadership, do you have access to simulation and do you feel that it's beneficial? Most people don't have access to any simulation after initial education programs. Overwhelmingly, everyone thought it would be beneficial to their providers if they had increased access to simulation. The next question was, would your agency benefit from regional assets like lower fidelity mannequins and task trainers? Now, overwhelmingly, they said, yes, we don't have enough of those, or they're old, or they've been used since 1980. So I think that that's another opportunity for us to provide additional resources so they can do quality in-house training. And then Page 20, this is our, from the hospital survey. And I think the most notable thing that came out of that was more than double the respondents said that the patients are undertreated and not overtreated when they're coming into the trauma center. Now, when we drill down and ask for some specifics on that, it tends to relate to assessment, not doing thorough enough assessments, not identifying underlying injuries. And so trauma assessment is going to be another kind of focus for our coordinators and some educational efforts that we'll see rolling out across the next couple of months. The final, just really significant point that I thought was notable for the coordinators and for our partners in education is that we asked medics about what's their confidence with critical trauma patients in the field. And another question was, how frequently are you training to manage critical trauma patients? If they trained more than annually, so twice a year or quarterly, they had a 50% increase in their confidence of managing patients in the field. And I think that speaks to, we need more training, even if it's less formal, it needs to be more frequent. Keep the equipment in their hand. Let's keep everything fresh, because if nothing else, their confidence in managing the patients is improving. And I'm happy to take any questions about the educational needs assessment or anything else.
First of all, this is amazing. This is an outstanding report. I don't think you understood it. But this is what we want from our sure. And I just want to applaud you and congratulate you on it's fantastic. Actually, all along stuff. But this is the word that's
Yeah, thank you. Thank you. I appreciate that.
I'd just echo that, Crystal. This, I mean, we want to help EMS, especially rural EMS, but all EMS out. And you don't know what they need if you don't ask them, and somebody asks them. So thank you for doing that. And some of these answers are a little bit surprising to me, but I think they hit, once I think about it, I go, that actually makes sense. So great work. And we just need to work to help out our folks that need training.
We had just an open comment at the end of the survey of tell us anything else that we didn't ask about. And something that several people noted was nobody's ever asked me the education that I wanted before. So thank you for doing it. And I just thought that was something we should do more of.
I do have a question. There's one graph on page 10 that caught my eye. Being on the EMS subcommittee and knowing that we worked for quite a long time. One of Courtney's big battle cries has been EMS education and making sure that there's funding and opportunity to educate the medics, because they're the first ones that show up. But 52% of the respondents are not aware of all of the education that gets. That was concerning. Yeah. That was a shocker, I will say, because it's been how many years and how much invested? It's not working.
It may not be the equipment. So that really surprised me. And the other thing that it doesn't surprise me is the difficulty in getting the education to them. And that has changed dramatically, I think, over the decades that I've been involved in EMS. And I'm very interested in seeing a little bit more drill down next year. Not that this is not great, but I still got, some questions. Why do EMS people not thoroughly assess a trauma patient? And is that because they don't know how? Or is it because they know how and they just are lazy? And they're not disciplined, to do the head to toe? And I think there's a little bit of both of it. So.
And I think there's also the perception of the hospital. If it was a nasty airway and the medics are managing the airway, they might not have noticed that there was a fracture somewhere that wasn't at the patient's airway. Yeah, I think there's more questions that we can ask. We can learn a lot more, but it's a good start.
That's a great point. There's some things you never get around to if you're still trying to do those life support things. Okay.
That's right.
But if nothing else, it helps us develop a roadmap for the future on what we need to do. The problem with that, when you ask somebody's opinion, they expect you to do something with it. So that's the challenge now.
So I want to compliment y'all also. Y'all have done an outstanding job with this data and compiling it and then putting it in a format that you can derive and see something out of. I appreciate it as well.
Well, thank you. We have lost our interns now. They have graduated, but they did a lot of the work on compiling the 30,000 or so data points that we got across the survey. So. All right. Thank you.
I want to ask the question I know Dr. Ashley's dying to ask.
Okay.
Can this be published in the Journal of EMS? Can we submit a manuscript to that?
No, I was thinking,
For you.
I was thinking that. I was thinking, because this will help other people realize what's going on, you know, I mean, you found. All that, so, yeah.
Yeah, I think that that's a great opportunity. The other thing is we really need to push this out across the regions. Most of the regions have some form of an EMS education subcommittee. Maybe that's through the RTACs or the councils. But we'd like to share this and get their feedback on it, but also they can implement changes as well, just based on what we learn from it.
Well, I think this type of data and information would drive a lot better collaboration between the EMS world and the hospital world through the RTACs.
I think so.
And that in certain regions of the state has been a difficult move.
It has been, but given some just tangible resources, I think that we can get more engagement that way. We'll work on getting published. Thank you.
Let's. Yes. Console, system console, to-do list, comprehensive EMS, education needs assessment, comprehensive role assessment, and then the money.
Start checking those boxes out.
You're done. That's what's in it.
Okay, we'll move. Who's doing then the finance? Is that Dr. Dunn?
I believe it is, yes. I recently found out that I'm the vice chair of the finance committee. So the lesson learned there is don't miss the meeting because you'll get elected to something. All right, so we are coming up on our the need for approval of our next year's budget, and we're going to go through that in depth. And fortunately, we have Katie to go through that. So Katie, I'm going to turn it over to you.
Great, thank you.
Oh, before Katie does that, there's our last budget subcommittee, Pete had raised a question about our staff, our Georgia Trauma Commission staff, and what their when their last raise was, or how are we doing merit-based increases? And we had not been doing that on a regular basis. So he kind of eyeballed it and said, well, you know, we should probably give them a 3.5% increase. Since that time, we had to run that up through the chain through DPH, and DPH said, well, why don't we just do a fair market value analysis? That's what they do for physicians, but there's another name for it for the governmental staff. But they did that and then came up with the number that's currently in the budget that that Katie's going to show. And I think we as a commission probably have dropped the ball on that, but we are committed to making sure that our staff are fairly and equitably compensated compared to the national norms, as well as, you know, getting rewarded for outstanding productivity and work. So I think in the future now we have a process in place to make sure that that happens on a regular basis. And that will be continuing on a yearly, if not twice a year basis. I mean, every 2-year basis. So, but so I want to thank our staff. They are high performers, as you can see by what's been presented here so far, and they need to be compensated for their work appropriately.
All right, good morning, everyone. Just going through some of the items that Pete had included on the report. It has been a busy couple months with the finance. We have approved the 2026 proposals that came from the contractors. We will go through those. And then some other items, the final spend plan for FY25 and the PBP that Gabby went over, we'll approve that. And then the FY26 budget.
Which page are you on, Katie, so they can follow?
I'm doing the scroll, 131.
Thank you.
Yes. All right, so this is the FY 25 expense to budget. This is provided each meeting. It shows where we're at, and this also includes the reallocation amount for FY 25 as well. I'm not going to go line by line, but if you have any questions, please let me know. Everything is in line, with the exception of the items for reallocation. All right, and then the budget timeline on page 135. We are in line with that. We are making or having the votes. We had them in the budget or in the finance committee, and then passing along to you guys for approval. Page 138 is the super speeder revenue summary. We are staying on an upward trend of 6% increase over last fiscal year. It's on page 141 that shows the breakdown. Then on 142 is the items for vote. We do not have to go through the performance-based pay slides, but those are in your packet to reference back. Liz, do we want to go ahead and make the motion on those as we come to each item?
We can probably do what we did on the finance committee, which is just make one motion on PBP.
Okay.
Unless anybody has a specific question. Gabby went over all of it.
All right, do we have any questions on the PVP? Yeah.
We just need a motion on to approve the PBP. Good point. Yes. So we don't need a second. You just need a vote, right?
We just need a vote.
Okay, any discussion on that? If not, we'll take the nays. Anybody that doesn't approve of the motion, please speak. Hearing none, the motion passes.
Thank you. The next item is the FY 25 final spend plan. The items that are included on this are items that we budgeted for and did not spend all the funds or did not kick off the project. There was only a couple of those. These went through the finance committee, and in the prior meeting, I believe it's been a couple of years, we voted that the finance committee could approve for reallocation. The only items that will need to be approved by the full commission are the firework revenue. So all of them are compacted together, so we can just do a approval to vote for the spend plan once we get through it. On slide one, or on page 171, this shows the items in our operation system development, EMS and trauma centers that we have left to reallocate. And then any questions on those items? It's just for operations. It's some of the budget items came in less, and that was our DOAS admin fee. Those came in less, and then some items in system development. Those are our tech regions that were not in place for the full year. And then EMS had their meeting last week. Yes, last week to vote on the remaining reallocation funds for FY 25. And then trauma centers are the centers not eligible for funding this year. They received registry and not readiness and performance-based pay and uncompensated care. The other items are our FY 25 firework revenue and then FY 24 prior year funds. So those are also trauma center funds that were not verified. So the items that are that need to be voted on are the stop the bleed, the 250 that we're going to reallocate out of FY 25, but it is also going to be a line item in future budgets. So it is a line item in the FY 26, but we did not have it in the 25, so we'd like to use reallocation funds to go ahead and get that started. So the items for vote, we did the 80-20 standard reallocation to the trauma centers and EMS. And as voted on last year, we have voted to hold the trust funds in reserve, the trust fund interest in reserves for any future projects. And here's the summary of the final spend plan. I know it's hard to see, it's small, but hopefully on page 175, you can review it in your packet. And we'll need to make a motion on that since it includes firework revenue as well. That is 175.
So Katie, we just need to.
Do we just need one motion for the reallocation spend plan?
Is that correct, Liz? Yes.
Yep.
Do we have a motion for the reallocation spend plan as stated in your packet? All right, since it came out of committee, I don't think it needs to be a second, but that's fine. Any discussion? All right, we'll go the same way. Anyone opposed? All right, the motion passes for the spend plan.
Thank you. The final item is the FY 26 proposed budget. We have received the approved budget. And then just a few items of additions, staff development. Liz, did you want to touch on that since you and Gina have already been participating?
Yeah, sure. We've done a number of, we're just, again, and to Dr. Dunn's point, I thank the commission for investment and development of our team. We have a small but great team and we want to continue to develop them. So we've started participating in the UGA leader development program. So we want to expand that to other members of the team as well.
Thank you. And then the other item, which Dr. Dunn mentioned earlier, was the staff salary increase, an average of 7.6% for a total of $44,857. And then in system development, our tech equipment. So DPH IT has requested that anyone with a .gov email address needs to use state equipment and not personal equipment. So we have started renting the equipment from DPH. We have one RTAC that is already doing it as a trial just to make sure everything works out well. But that was a request from DPH IT. So we put a budget in for 2026. And then, as mentioned before, the Stop the Bleed budget of $250,000 as a budget line item to maintain Stop the Bleed training initiatives and equipment. Some variances for FY 26 increases is office telephone and internet, and that's to improve the broadband services also requested by DPH IT with higher security for the Madison office. And then in the GQuip proposal, we have additional roles, which we have already had those in place with FY 25 funds and reallocated funds, but those will also be in the FY 26 budget, and then a slight salary increase for Emory in their proposal. Decreases were meeting expenses and staff sale have decreased. On page 179, this is the one page that shows each line item from operations, system development, EMS, and trauma centers to distribute the FY 26 budget. And then on the following last pages of this report show a line by line. We also did a historical budget comparison from 23. So you can see the increases or decreases that have occurred over time. And then your final column out to the right is the FY 26 proposed budget. And this makes up that one pager total line. There are no significant increases or decreases other than the ones discussed in the slide. So if you have any questions, please let me know. And then we'll need a vote on the FY 26 budget.
That also comes forward as a finance committee because you guys passed it. Yeah.
Just one question for GQuip, the Emory salary increase, what is that for?
Gina, do you want to?
Yes.
Okay.
So for Dr. Sharma's time, we actually do a 10% time buy down for Emory for that. So if his salary increases at Emory, the 10% of that cost us a little bit more. So that's where that increase came from.
I mean, should that not just, should his compensation not just look the same as the compensation of the folks on the medical director side of the trauma?
It's a great question, but it's not the way the contract's structured because we group Sharma and the research fellow together and do it through Emory, which is the way they preferred it. If folks in the commission leadership want to have discussions with Emory about breaking that apart, but I think it's part of his academic productivity.
Yeah, I'm not trying to be difficult, but just because his salary increase is the value of the work we're getting from him increased dollar wise comparably, I would argue it doesn't change what we get in return. Maybe I'm being too nitpicky, it's probably nominal, but just food for thought.
Yeah, and I just know historically that was the way that Emory required it to be done. They would not let him
Do
do
it
not
as a
contract
separate
with him
contract.
outside of his Emory time. So, of course, could that be revisited? Because that's been a while, possibly so, but that's why it was set up that way to begin with, is that was their requirement it was a buy down of his time.
Right, that, my understanding is that that's a contract-based issue, and if we want to change that, we're locked in by the contract, so if we want to change that, we need to revise the contract or give them a new contract, and we have not yet done that, so.
Yes, or have the discussions with Emory, could he contract outside of Emory? Because my understanding is that was not allowed. Yeah.
That helps them go with this for everybody that works at Emory, that are working with the commission in one shape or form, should be at some of the contract, should be based on an hourly, reimbursement, and goals.
Yeah, because like the research fellow, we pay 80% of that salary, and then 20% is delegated to Emory pays for, so.
All right, do we have a motion for the budget as presented?
Motion from the committee?
We don't. All right, well, then I guess we do any discussion.
All right, I take it, no vote, anybody that disagrees or opposes the budget as stated.
Okay, the budget passes.
I have one additional item from the finance subcommittee to come before the commission for a vote as well. As you guys know, we've brought up a few times now that the verification visits under the Gray Book have been a bit more challenging than we have experienced historically. And states outside of Georgia, as well as ourselves, are now being faced with unsuccessful verification visits. And we have funds allotted for those facilities that we are holding. They maintain their registry funding that was approved by this group in the past, but they lose, if it's a 1 and 2, the readiness and uncompensated care. And the 3s, they lose their readiness. So we've got that pot of money. We don't want centers to leave the system, and we wanted to discuss in the finance work group some mechanism by which we can continue to support them to be successful and become re-verified. So we've come up with what we're calling the STRIVE grant, that's support towards readiness, improvement, and verification excellence grants. It would only be available to those centers that receive a no verification letter following their site visit. It would be on an application basis that they would have to apply for, and there would be specific items that we would support as a commission to help them get back in line. And what we are asking is that the commission approve the funds that we withhold from centers be set aside in order to support these STRIVE grants. Liz, do you have any other feedback that? there was a work group that kind of talked about this. We didn't want to say, okay, you're not verified, so boom, you're out. We don't want to deal with you anymore. We want to help people to get back into the system since it's important. And we thought this might be a good way to do that. So
And I think this is really for, because the ACS has changed their visit outcomes. So it used to be that when you got a no verification, you had to reapply and start the process all over again. Now you can get a no verification and then a corrective action review. So technically this would be for the no verification outcome of the corrective action review. And it's not intended to pay subspecialty call pay for services that you don't have. It's intended to help, which the ACS says most of the no verification outcomes are largely related to PI processes. So it would pay for those things that would support development of PI processes and getting it to where it needs to be compliant to pass the site visit.
So just a couple comments on that. So if a center fails an ACS verification, they lose their readiness funding, period, end of story. And we have to do that if we want to maintain a standard here in Georgia. At the same token, as Regina said, we want those people back in the system. The money that they lose is going to be set aside, but they can't apply for a grant for the whole amount of money because then it's just a silly process, right? They're still getting their money even though they failed. So it's a portion of the money that's being set aside that they can get back to help them, obtain verification, but it's not the entire amount. And that grant that they apply for has to be reviewed by a work group to ensure that it makes sense, right? When I first heard this, I said well, then they could just apply for a grant for their whole amount of money and they still get their money. So what's the point? But it's not that. It's for a much less amount than they're going to lose. They will still lose a significant amount of money by not being verified, but we want to try to help them get back in the system.
And then I guess part of that application process would be how they're going to use those funds. And then they would have to submit some sort of proof. Yes. Okay. Excellent.
And from my understanding, it would be voted on by the commission, right? Or the finance committee. Somebody would approve that because each application might be different. Like one group might need a consultant on PI, one group might need a consultant on whatever. And there wouldn't be a template that everybody has to use. Is that correct?
So we have a standardized application process that you have to fill out so that it's the way that you apply for it is standardized across the board. Everybody's got to complete the same information. And then we had a work group to put this together. So I would assume out of the finance work group, or we would put a group together that would review. There would have to be a group that reviewed and either approved or not approved the grant application. Like she said, we're not going to pay locums ophthalmology coverage kind of thing, because we can't do that. That's not a sustainable solution. These have to be sustainable solutions so that they can become verified and remain verified. So yes, that would go before that group for approval, and then we would report it out through finance, which centers applied, who's received it, and that kind of thing. And then we would track to make sure they're actually following up on what they're supposed to be following up with, because the whole idea behind it is for them to be successful and for us to support them to be successful to get back in the system.
So just for clarification, what do we have a set percentage of what has been set aside that they can apply for, or maximum?
No, we don't know, because this is the first, we're just coming into this now. Centers mostly under the Orange Book have been successful with their verification visits, and now under the Gray Book, we're having people not be successful and having funds withheld. So we don't have a max percentage. I think it's going to depend. Say, for example, you want to bring in a consultant to help build, your PI or your processes. Consultant fees range, obviously, but like Jim said, we've got to be cautious. It's not, I don't want to say that we would think anybody would try to game the system, but in the rare occurrence, somebody would submit a request for the amount. That would be kind of suspicious. So, but we could talk about that, putting a cap on the amount that they could get. I think that's where we're going to have to just see what centers are asking for. Because it's new, we're not really sure what is the best way to support these centers. We just know that we want people to be supported to get back into the system. And what does that look like? It's new for all of us. We don't have an exact formula for that yet. And I don't think any of the other states do too, but they're all faced with the same situation we are, where now you're finding, some of your centers that have been verified centers for a long time aren't passing. And how do we help them? Because it doesn't benefit anybody to have centers drop out of the system.
Right. The other thing I wanted clarified. So you said it's when it's a no after the corrective action.
No,
After your verification visit, yeah, I don't,
No,
So
I
if
guess,
you-
I guess what I mean is, we cut off the funding as soon as they get the no from the verification or after they get a no from the corrective action?
so funny you bring that up, because Gabby asked that question. So we had a work group look at that and we made the decision. So make sure I say this right, because we went through 50 million scenarios trying to make sure that we had this correct. So I'll give you an example. We are coming up with our visits are a week apart. So April, say we're having our visit April of 2026. We have our visit in April, and if for some reason I get my letter in May that says, sorry, but no go, you fail, then I would not be eligible to sign a contract and receive funding for the next fiscal year. If I don't get my letter, I have my visit in April, and I don't get my letter till August of within that fiscal year. You maintain your funding for that fiscal year, but I lose the next fiscal year's funding. So regardless, if you get a no verification, you're gonna lose at least at a minimum 1 year's funding. If we get reinstated within that next year, then we will be eligible for funding the following year. So that if we don't, then we'll lose 2 years worth of funding. So everybody will at least lose 1 year of funding. Where the letter falls will be, is it the next upcoming, or will it be the following? Because it's hard to pay a portion of your funding.
Right.
He's gonna tell you they lost more. No, you didn't.
Yeah, I guess the question I have is, and I know we talked about this, and it gets really confusing, so.
Well, that's what made it almost impossible to come up with a clean cut.
Yeah, but what if they got verified in that before the next year?
Then you get the next year's funding, and no matter what, you lose a year's.
So you're gonna lose it no matter what?
Yeah. One of the walls.
Yeah.
Ticket plans.
Yeah.
Right.
So what is the usual, or do we even know what the usual timeframe is between a no contingent on corrective action being taken and when the corrective action decision is implemented? In other words, it's not like a 3-month process or anything.
The program we're talking about is really for people who've gone for several years without being able to fix it.
Okay.
Okay, does that make sense? It's not.
Yeah, I
it's-
was just
it's
thinking
not
like
for
if you got a no,
cause.
but 3 months later they said, oh, you
Yeah.
corrected what you need.
It's
And-
not for that.
Okay,
That's
gotcha.
why, as I'm reading our grant, as I'm reading our application that we're fine tuning, the only other thing I want to make, because this isn't just for somebody who, because now, again, the process changed. Before, you could get no verification, you had to reapply. Now, according to their algorithm, you can get a no verification and get a corrective action. Sometimes you don't get your letter of no verification until 4 months, and then you really only have 8 months to get your corrective action in order and have them come back because they put a shelf life on it. So this is for, I have my corrective action and I still get a no verification. So there's an indication that there's some probably foundational issues there. And to try to figure out how we can support, most likely it's going to have to be somebody coming inside the building from outside to give some guidance and suggestions about. I think the college used to be a little bit more free with the script with telling you. Now it's just very suggestive of.
Well, and you could get your scenario was more in line with, and they've always done this and they continue to do this. Probably all of us who have been verified for multiple years now have experienced this at least one time where you get a 1-year provisional. So you'll get a site visit, you'll get a letter, you'll have whatever the deficiency is, and they'll say, okay, you can have a 1-year provisional verification. So they verify you for 12 months. And then you usually have 6 months to submit either what they call the administrative corrective action or a focus visit corrective action. For us, it was registry. We lost a bunch of registrars. We fell behind. So we had an administrative corrective action. So we had to send reports monthly out of the registry for 6 consecutive months showing record closure at 80%, 60 days from discharge. And then once we were able to satisfy that, then you pay them, but they send you a letter then that extends you the additional 2 years. I couldn't apply for funds to get a registrar or a contracted registrar for that. That's not appropriate. If, however, we had any level one, missed any level ones and more than 3 level twos, and we were not verified, period, and had to go through their process of being reinstated. So they take you right off the list too. Your name comes off the website and everything. And there's an issue or something that I'm totally lost with, or we're not going to be able to do something easy. If it's subspecialty, the administration's going to have to come up with the support for that. If it's administrative commitment, there's no money. I'm not going to pay your administrator, something like that. Yeah. So, it is centers that we have some that have been not verified for a number of years that want to be in the system, and we can help them because they're struggling, that kind of thing. So it shouldn't be something that comes up on a regular basis. We're hoping it should be a rare occurrence for somebody to be with and to reinstate them and get them back involved.
Sorry, no, but so just something about this. So you're guaranteed to lose 1 year of funding. But are we setting up a scenario where, dependent on when your site visit is, you're more likely to lose 2 years, and that's totally out of your control?
If you don't get everything there. Yeah.
But-
potentially.
But what I'm saying is, if my verification is early in the year, I essentially have 23 months to fix my problem.
Yeah.
And so I lose 1 year. And if my site visit is opposite of that, now I only have 13 months. You see what I'm saying? Are we setting up centers for, based off the timing of their site visit, greater chance of losing 2 years of funding? And that's out of our control as a center as far as when our site visits are. I just worry, I mean, we can talk outside of this. Are we building a model that penalizes people based off of their timing of their site visit?
I
which is under
think,
control?
I think we're mixing two things here. So yours is a good question, but it doesn't have anything to do with what we're talking about here. But like, what I mean is like the way I understand it, the Strive thing, we got to figure out, are we going to do that or not?
Yep.
Your questions are very good, as that's been hours and hours of discussion with your all's group about that timeline. So, and I'm a little confused myself. Did we pass that or did we not? So maybe Regina could give us a comment on that after we get this Strive off the table. Let's get Strive off the table or on the table.
I like.
And then let's answer your question.
I
Okay,
would
so
make
I
a
just
motion.
want to keep us going in the right direction. All right.
I'd like to make a motion to approve the ability to utilize the withheld funding for centers to support the Strive grant process. I'm just gonna leave it at that. Gabby, we can wordsmith it.
Regina, do we need a second?
We need a second.
Yes.
Okay, any discussion? I think we had robust discussion. Okay. Let's just take nays. Nays, any nays? Okay, so Strive is alive. Okay, okay. Now let's come back to Dr. Todd's question, which was a very good one.
Well, and I'll make that.
And
a comment
does that need
on
to be answered here? So I'll let you direct us on that.
Well, I do think this committee, that our work group had headaches, and we probably need to revisit it a little bit. But I will say this, especially as a center, and you probably echo or disagree with me. I have a center coming up for their level 1 re-verification. We know if we're going to pass, you know it. So if you're struggling with something, it should not come as a surprise to you. And even with the deficit we got with the registry, we had already put things in motion to correct it, which is why we were able to correct it in a timely fashion. So I think this is for centers that are really struggling, at risk of losing 2 years funding. Yes, there is risk of losing 2 years funding, but your program should know your at-risk standards, I would think.
I was the risk of 2 years really comes down to the time of survey.
If you wait,
So
yeah.
we know that from,
Yeah.
going into this, we know we're doing contracts, you know that, you know what you're doing there. Okay? If you want to revisit it and suggest.
But I was thinking about, I was saying, we need to talk about it.
But I think it's gonna set up in the Facebook page too, is that I think that there's really see the language and the contract to have a lot. To be living with it. So my recommendation to you, Sharon, is to get back to the lower grade. Just to make sure they let it all out, start at a ATV sheet, load it out there and get it back. We've not been faced with this before, senators that have not been verified, when we think about that, and I don't think there's a perfect solution. You gotta come up with what's fair, and everyone. Yeah.
Well, I think, so mine is a question and a process. So, because I've monitored some of your all's work group thing and actually been on some I haven't. So what I think we need, and you all help me decide what's the appropriate timeline, but I think we need something in writing or something that we vote on as a commission. And because this could be a nightmare as far as geopolitical. We need to be transparent upfront on the website where people can go and find it, and we don't even talk about it. So we want to be proactive. So my request would be that we get something, a motion in writing, maybe even a table, like, and I'd like it very simple. Like if you go out in January, if you go out in February, just make it dummy proof. And just, if you get your letter this month, this is when you will lose. I mean, I don't want anybody having to figure it. Certainly I don't want Liz having to figure it and then tell centers. I want it like, go to the website. And I'd like that table presented at the commission. So we can look at it and vote on it and say, this is what we're going to put on our website. And then it's out of my hands. It's out of our hands. So what would be the appropriate, and what would be the appropriate timeline for you to bring that forward for a vote and to get that done?
There's gonna be a lot of work, unless you make federal province centers who are usually in junior patients. It's gonna be really hard, but I would say it's spring, let's schedule a work call and let's get all work clear.
Otherwise, we try to do it half a year. When we got your letter here, this, there, so complicated to make. And it's here for the last, probably came out of it. But any time in that period, it's the last 75. So even if it's June 30, it's July 1. And next year, now, the budget can be an allocate money, we don't know who's gonna be in our allocate money. So the downstream effect of the decision, not only impacts the centers, but also the commission and how it also we gotta have a cost of it, and it is gonna be. Or actually, it's gonna be that candidates back.
Yeah, it doesn't matter to me. I just want you to write something down and so we can vote on it and so we can post it. That's.
The table's up on the screen now. It is hard to see on here.
So let's just make it simple. Let's look at this and float it out to the commission members before the meeting so people can look at it. And let's just vote on it. I just want to, again, nothing will be perfect, but if it's voted on, it's up there, it's written out, and we're not making decisions like, well, I like this center better than this one. We're going to give you 6 months of no funding. We're going to give you 12 months. We don't want to be accused of that. So that's all I want. So I think next meeting is fine. And let's make sure that people know about it before the meeting. So when we get to the meeting, I want a clean, unanimous vote. Okay, is that fair?
See Ron sketching it out over there.
Okay.
Table.
All right.
Yeah, it's all, we made it, I mean, you really, it can be a matter of 2 days difference. And you have 12 months to fix your problem, controllers are your system.
Right, sure.
That's the, I mean. You don't really have control over it. So I mean, one day difference in which letter can make a difference, because your problem was. That doesn't come. And we talk about, I mean, and I agree too now, I think. But it still doesn't matter, if letters go on one day.
It wouldn't come on that day, but I would know that the filer is gonna come.
Can I make a recommendation? We just send this to the committee. We're already an hour over our timeline. Let's just send this to the committee and the committee can report on.
Okay.
Question, would it go into the committee before the contracts come out for FY 26? Though that will need to be decided on before we release those contracts for 2026, which occurs in, it's gonna be a little later this year because of the overhaul. So how do you want to handle that?
It's the chair. You're the chair.
Can we just put that to the committee as well? Because I don't think we can.
We
make
have a
determination.
question here that I'm not sure I quite understand. Did you hear the question?
The contracts.
It will be in the upcoming contract, so we need to determine.
We could have a call meeting, maybe.
So do we need a called meeting? Like, we need to get this off our plate. That's what I'm saying. So do we not, do we really need to wait to August? I mean, this is an important thing. So I know we don't have time, but so when, I mean, it could be virtual too. You know, virtual meeting.
So let everybody agree on when it comes forward, and then the full commission can meet just to consider that.
So Katie and or Liz, when do we need to have, when do we need to have our piece of paper for you so you can do the contracts? You set the time.
We have a little bit more time now because we're revising.
Correct.
I just need a date.
I would say
Ask the committee to have this.
June 1st.
So then.
June 15th.
That we need to meet,
Actually, June 3rd
we need to meet for a vote on the 13th.
to approve the language of how the timing will go relative to the letter.
So you need, so we need to, could we meet then on the 12th or 13th virtually to vote on it? So that means the work group has to have a working product a few days before then for to be emailed out to the commission members to make sure they understand it and don't have questions.
Yep.
And then if you do have questions, don't call me, call Dr. Todd. And they will know, they can answer those questions. It sounds like you have everything done, but you just need one sentence or one tweak in there is what it sounds like. So. Okay. All right. Do you need any clarification? Are you good?
Clear, crystal clear.
Crystal clear. Okay. It's a complicated subject. That's why I just want to make sure we get it right, because once we do it, there's no going back. Not very easily anyway. Okay, let's move into the EMS committee report. Courtney?
At last full meeting, we asked for all the partners, all the collaborators, the folks who collaborate with us to bring back a report. That's where Crystal's group brought back the education assessment. We had a report from Jim, so we had a report from Dr. Boone and some other folks on what they thought we should be going forward with. Now, there's still some things I think out there, some things I have requested. People give me some ideas about what we can do, particularly with assist and helping the education piece. We are meeting, I think, next Thursday to vote on those budget items. It might be a long meeting, but we will get all that done. Love for y'all to come. We also met a call meeting to go through our reallocation money. Katie and Liz and the staff were kind enough to put together a a packet for us that made the meeting very quick. We got it done, and we got that done fairly quickly. The next thing on EMS education, I'll talk about it for a minute or two, but then I want to ask Crystal to do some stuff. One of the things that we do is we fund initial EMS education, because if there's anything in the state, I think that is critical to the success of our profession, is getting enough people to do the work, and that has been real problematic. Decades ago, the technical colleges were very robust in teaching these classes, and that has fallen by the wayside in a lot of areas of the state. And unfortunately, most of those, at least in my opinion, are the rural areas of the state. So we have, over the years, developed a process to fund initial education. But we've had a huge variety of success. We've had programs who had great success where all of their students pass. We've had programs with very poor success. And when I say passed, we consider success to pass the National Registry, get a license, and go to work. So we've had a great deal of variation. It's frustrated us a little bit. And this past year, we working with Crystal, because she knows this gentleman, but we actually did a little bit of a search on looking for someone who could provide testing modules or test at each individual each individual module, so we could determine the success rate of the student at the end of that module. So that became part of the contract. It didn't cost the program anything. They simply had to have their students go online and take those modules. And we've had some variation there too. We've identified a huge communication problem between our committee or our subcommittee and the EMS instructor or the EMS director there. And we've got a plan that we think we can resolve that with. But what we did, we started last year with that. And the company is MediPrep, and they provided us with they've twice given us some data. The last data I was particularly impressed with, this in your packet, and I'm gonna pause just a minute, turn it over to Crystal. One of our goals was to try to, one, improve the pass rates, the success rate, but the other thing, look for some kind of a trigger early on in that student's learning process, that we would have an idea this person's got a problem. So we didn't wait till the end of the course and they failed and then kind of throw up our hands and said, what happened? So Crystal.
All right, so we started this program again early last year. We've had several hundred students that have participated in the testing so far, in the neighborhood of 600 students. Well, we were able to get voluntarily 3 of the programs submitted their National Registry pass information. So not just as a course, we had a 70% pass rate, but for individual students who passed on the first, the second, or the third attempt at the exam. Jeremy, the owner of MedEd Prep, was able to take that back and correlated it directly to these exit exams throughout the program. So EMS operations, airway, medical trauma special patients, and then a final exam. And what we found is actually really exciting. I'll talk about something to publish. So it's just 3 programs. We'd like to have all programs report their pass data moving forward. But essentially, if you'll look on page 189, essentially by taking the exit exam pass rate and the National Registry success rate, we're able to be quite predictive now with our initial education programs on who's going to pass National Registry. Now, we want all of them to pass. And like Courtney alluded to, if we can identify certain trigger points that this is a flag, we need some remediation, we need to fix a problem before they get to registry, hopefully we have more successful students out of the program. So our critical thresholds that have been identified so far, the EMS operations exam, if the student makes greater than an 80% on that exam, they're statistically going to be more likely, 92% likely, to pass the National Registry exam. Airway and respiratory, greater than 70% is the same predictor. And then on the final exam, if we have a student that makes less than a 65 on that exam, they only have a 30% chance of being successful on the National Registry. as Courtney said, we had a lot of kind of uptake issues with the program because it's something new and it was required and they didn't necessarily understand why it's so important. We can validate now why this is important information for the instructors to have and then the students to have as well, right? Maybe you feel like you're coasting through the program, but if you're not going to pass the national registry at the end, then this has not been a useful expenditure of your time, right? So I think that we're only going to get stronger in those predictions as we have more data to input. But basically, we've set a couple of triggers throughout the program, 3 specific data points that we can look at. And with 92% success, we can be predictive on who's going to pass the exams. And that's where we really have the opportunity to fix it. Similar to the educational needs assessment, what do we do with it moving forward? Right? How do we integrate this into providing a resource for our initial education instructors? And how do we make them better in the classroom and make them stronger? Again, all of this is non-punitive for our instructors and our students.
It's not really right now, or it's just an idea.
We're doing it right now.
So Jim said is agreeable to this, to have their forces to do this, or to have instructors that forces to do this.
Yeah, so they did put it in the contract for their initial education providers for people who applied to host a grant. And that was a requirement dictated by the EMS committee.
We've had some pushback from individual instructors. And I think that's where I feel that we've got a problem with our communication. Some of them look at this as just more work for them to do and just an extra burden on them. And I will speak in just a minute about the burdens on some of the instructors and the hoops they have to jump through. But I think if we explain to them this data, that they can use those tests to predict an individual student's success. And early on in the program, they can identify that and then they can work with that student. And they can, in all honesty, they can sit down with a student and say, hey, here's the deal. If you don't get better, you're not going to pass. If you don't, we can't work with you to get you to where you need to be, then you're wasting our time and yours.
And something we've identified is that many programs weren't requiring any testing throughout the duration of the program, or maybe they weren't using a validated test bank. They were using something from the publisher, or they were writing their own questions. So just by providing the resource, we haven't done anything with it yet, but providing the resource, we've got an increase in pass rates. Right now with our grant funded programs, data is very early, but we were at a 64% pass rate of our grant funded programs, which was less than the state average, which is what prompted Courtney to have some leadership on this. Like, this is a problem, we got to fix it, right? We anticipate right now, I project that we're going to have increased our pass rates by 10% by just providing the resource to our programs. And that already this year would equate to over 50 providers in the state just by having the resource, not by fixing any of the problems.
You can tie that to dollars.
There we go.
Because everybody that we train costs a certain amount of money. If you increase it by 10%, you save a bunch of money and provide more medics in the field.
And then just one last thing about the test prep software is we actually look at every single subject matter throughout the duration of the programs, about 500 different data points. And so we can also get some pretty good information about where do we struggle with EMS initial education, trauma across the state, which really surprised me because I thought that was one of our easier subjects, specifically chest trauma. And then we can also drill down inside of chest trauma. Is it pneumothorax? Is it rib fractures? Like, where specifically do we have knowledge gaps that we can address those as well?
So what's going on in the real world, particularly in the rural area? And Terry's been a great champion in Lawrence County, and there is tech school, literally 3 miles from your office, but they don't do EMS programs at all. So Terry's staff at the county expense, I think y'all do 4 classes a year. They do some in the high school and some exterior. And Emmanuel County has been doing their own. And quite frankly, if we weren't doing our own, we would not be in the EMS business today. So the other thing that we're trying to work on is to give particularly the new instructors, but any of them, a toolkit so that they have a complete lesson plan, and curriculum that's helped, that touches all of the parts that the National Registry requires the student to know. So going in, they have that. And because a lot of these are, Richard calls them pop-up classes, and they are. The service pops them up when they have to have them. And the instructor doesn't have 3 or 4 or 5 years of experience. So they don't do well. And we want to try to get them to where they do well out of the gate as opposed to learning later on. The other things that we did, we heard from funding requests from 7 of the 10 RTACs to help to do training classes, and we'll be discussing those at the next meeting. ADLS, we continue to work, and we did fund some of that through the reallocation. We continue to have that program. The EMS equipment grant is probably one of our more popular things as far as the directors are concerned. We finished that thanks to Katie and Gabby in a timely manner, and we will be considering that again. Inter-hospital transportation, we continue to discuss that. We don't have a solution. It's what my book calls a complex problem. There's a lot of pieces to that puzzle. We did get some pieces answered with the work that Dr. Bolger did. We now know where a lot of our resources are, definitively know where they are. I think what I would like for us to do is continue to work with her and drill down. You know, we know it's an EMS station, but we don't know what level of care they provide. We don't know what equipment they have. We don't know what their policies and procedures are in dealing with time-sensitive emergencies. And those are the traumas, the strokes, the STEMIs, and some levels, the PEDS. So hopefully we can continue to work with her or someone like her to drill that down a little bit more. And that is my report. And if there's a question, Terry will be glad to handle it.
Courtney, I just wondered, Dr. Maves actually came today, if you wanted to introduce her and maybe give a little March Clause update. I didn't get to introduce you before we started.
Yes. Would you come forward just a minute? We finally back rolling with the March pause. And obviously that has been forever and 2 days. And also in the back, Kyle Payne. Kyle came to the last meeting, but we're in the process of trying to get Kyle to interview some of you so that we can develop the videos that we're working on. We are working with AU and the last meeting, they had the GQuit meeting and I got sick and left. So I didn't hear the presentation, but I did get a shot at it. Would you give them a brief scenario of what you are doing?
Absolutely. So I'm Erica Zimmerman Maves. I'm one of the trauma surgeons at, I guess we've changed our name 6 times now since I was a resident in 2013. Okay. So we're now Wellstar Medical College of Georgia, at Augusta University. I was recruited as director of surgical simulation. So when you start talking about skills training and simulation, you're speaking my language. That's been something I'm really excited to work on. And so I ended up getting in contact with Matt Lyon. And so Matt Lyon reached out to me and basically said, hey, we have this rural emergency practice conference that he runs every year, and they recognize the need for trauma training. And part of that, so we started collaborating, this was about 1.5 years ago, starting collaborating to create a conference-based simulation curriculum, which we delivered our pilot in February, which went very well. We did a needs assessment, and I loved seeing your chart. I was like, oh my gosh, every single one of those things, trauma resuscitation, chest tubes, airway management, bleeding, hemorrhage control, all of those things were in line with our needs assessment and what we recognized. We actually took it a step further and we did a needs assessment, and we reached out to our own institution to see, okay, so we know what the rural providers are saying that they need training in. What do we see that are training gaps and deficits that may be life-saving and be able to be addressed prior to their arrival at our facilities? And so we basically put the needs assessment together to inform the development of the curriculum. Ended up being a 2-hour interactive, there was questions, didactics, conference-based morning. And then we took all of these things that we deconstructed, and that afternoon had a simulation session where we addressed all of these different things. So it's really interesting, and it's awesome hearing you guys. My resident actually presented at GQuip the needs assessment and the development of the curriculum and our implementation. We're now working on feedback that we've gotten from the curriculum, as well as quantitative data from kind of the decision tree that we saw people were answering throughout the conference during the didactic session. So this kind of all led to introduction, and I met with Liz and Crystal, and we started thinking, okay, how can we start collaborating and working together on these projects? And then I know Courtney was working on the C March Pause, and I met with him offline, started working on the slide deck from that standpoint. And one of the things that we proposed is I have the need for a surgical simulation fellow, a surgical education research fellow. And that fellow is going to assist with delivering rural outreach initiatives. And so we are going to be working together to try to fulfill the needs for the C March Pause between myself and my fellow, as well as any other rural outreach. So this is very early in the stages of planning, but I'm really excited to work with everyone. Thank you so much for having me here, and thank you for including me in this. Listening to your presentations this morning, you guys are doing a lot of really impressive things, and so I thank you for the opportunity to work with you.
So this was happenstance, I think, more than anything else, and it has worked out well, but the plan is to help fund their program, and their program would support the C March Pause program. And, you know, one of the things that we look at is as the C March Pause is, some people may refer to it as an entry-level course. Some of it people refer to it as an appetizer, and the full meal would be more of what they're doing with their simulation labs and their cooperation, I think, with Georgia College of Emergency Physicians. Y'all have a relationship and teach these classes. So if we could merge those together into a process, then I think we will benefit not only the EMS provider, but the hospital provider and the physician provider with this part. So that's where we are. We have come to an agreement with AU about this process. We've done the budget. We've got a contract out, and Liz and I are going to talk about that a little bit more today to find out how we can make that a little smoother, and we've got it right at the moment. So any questions about that? Or any questions about the report? Terry's still here. Thank you so much.
Thank you so much.
For coming. I'm done.
Great report, Courtney, and I'm excited to hear our collaboration here. I knew about this, but just we hadn't got a chance to meet. So thank you for being here, and looking forward to the continued good work here. So we're running way behind, but we've had great discussion, so I didn't want to squelch any of the discussion, and the budget always takes a little more time than you think. But so why don't we break here for, what we got, 15 minutes, 15-minute break? And reconvene at 11:40. Does that sound good? All right. Go ahead and get started again here. I'm going to change the order just a little bit. There's some time constraints. I'm going to see if Dr. Walker is online to see if we can move into the Trauma Administrators Committee report. Dr. Walker, are you available?
Yes, I am. Good morning. It's still morning. Good morning, everyone. Hopefully you all can hear me. And thank you so much for letting me move up just a little bit. And in fact, you will notice that you do not have an official trauma administrators report in your packet. The trauma administrators did meet, but unfortunately it fell into the donut hole between the time that the committee report outs were needed to make sure they had them in advance enough to pull them together and put them in your packet. So I apologize for that. Additionally, in a good way, I think I can save us some time because much of what was discussed at the administrators meeting has already been discussed and voted on this morning by the commission. But I will just let you know the high points. Of course, Liz gave a general trauma commission update, including the budget updates. Gabby provided updates on the performance-based pay, as well as the overview of the level 1 and 2 readiness cost survey. And the administrators committee did get to see the web page that Liz has already talked about, and it is an excellent resource. So kudos to the development of that. Also, Liz went over the trauma center KPI worksheet, which has already been discussed today. The one item that we did spend some time talking about that is new, and we've not heard this morning yet, is Pam Vanderberg from Grady gave an update about the beta testing for the ESO registry. And we had some robust conversation around that, since there will be some potential cost increases if we stay with that registry. And as hospital administrators, we're all about the budgetary implications of some of these things. And so Pam told us about some of the difficulties that they have had being a beta site and working with ESO. And it's a little concerning, some of the things that she shared in terms of lack of GQuip or state templates, some limited data visibility and mapping, also some major problems with report writing capabilities, and again, the substantially increased cost of the ESO registry. And they are suggesting that there may be an additional app that we would have to purchase on top of ESO that might solve for some of the problems, and that would be at an additional cost on top of the increased cost of the registry. So we had some robust conversation around that, and I know that the registry work group is exploring some alternative options given these concerns, and Liz stated that we may need some administrators and medical directors in that work group to really provide a full multidisciplinary approach. So that's really the highlights of the administrators meeting. We'll make sure that we are getting our committee reports in time for the meetings in the future. Our next meeting is going to be in August. So that's all, unless anyone has any questions or comments.
Okay, thank you, Dr. Walker. Great report. And I'm glad to see that the administrators are involved with that registry question, because that you guys are in charge of finance. So, I mean, that's really a good strategy. So any questions for Dr. Walker? Okay, thank you, Dr. Walker, for your report.
Thank you.
All right, we'll get back on track here now. Is Dr. Register available for the Level 3, Level 4 Rural Trauma Center Committee?
Hey, guys, good morning. Hope everybody's doing well.
Good morning, we can hear you. Go ahead.
Good, awesome. Well, I'm gonna zoom in on that screen a little bit because I'm on my phone. So I'm really glad that we already talked about March pause earlier in the meeting, because that was a really good kind of recap of where we've been and where we are and where we're headed with March pause. So I think all of us that heard Dr. Moore's presentation of what Augusta has been doing at the last GQuip meeting is really encouraging, and I'm excited to see where this partnership with AU and March pause is headed. So more to come once that develops. And I think that the Level 3-4 subcommittee will be a great platform to then reach out to the rural centers that could benefit from this simulation, and take it out to the even smaller centers that aren't designated trauma centers. So that's it for March pause. The Pennsylvania Trauma System Foundation is coming back in June next month. And so 3 of the 5 original Level 4 centers that initially had their visit are going to have them come back again, and just reevaluate the progress that we've made since their original visit a couple of years ago. For the inter-rater reliability process, this is for the Level 4 centers only. So the commission has met with Q-Centrix to discuss the implementation process. So basically, this is going to help confirm the accuracy of the data from the level 4 centers that's being uploaded into GQuip. All of us know how important it is to be able to validate your data. And so this is just one of the many processes the commission has given the smaller centers tools to help do that, to validate our data. And then lastly, so we've made a lot of strides and progress in the short 5 years that the Level 3-4 subcommittee has existed. And so we don't want to stop. We don't want to lose momentum. So we're going to send out a survey throughout the Level 3-4 group and kind of reevaluate, okay, here's what we've done. What are our next steps? What are our next goals? What do we want to achieve? And so we're going to roll out that survey shortly in the next couple weeks, excuse me, and be able to bring that to y'all at the summer meeting. And I'd be happy to entertain any questions or comments about the Level 3-4 group.
All right, great work, Dr. Register. Thank you. Any questions?
Yes, Dr. Register, this is Dr. Dunn. Yeah, I agree with Dr. Register. Great report, a lot of good things happening. I would imagine that the rural subcommittee has access to the ACS state review, trauma review that they did several years ago. Is that correct?
Yes, and that is something that we've been going over in our most recent committee meetings, and that's actually what we're going to base this survey off of, is going back to what did the ACS say we needed to improve on, and how can we meet those objectives.
Perfect, excellent. Thank you for the update.
Also, we, Dr. mentioned the work group. We're bringing the fours together to review the new ACS proposed standards.
That's right. I think that call is coming up maybe next Wednesday or 2 Wednesdays from now. I have to check the calendar, but yes, that's also something that, the ACS is in the process of developing a rural trauma group. And so, we keep saying rural for this committee, and I feel like I need to correct myself. It's not just rural, it's Level 3-4. So there's some urban or suburban Level 3s and 4s out there. So I don't want to neglect or ignore them. But I think that in the next 3 to 5 years, as at a national level, there's more identification of the difference between a rural trauma center and a non-rural trauma center, and how the resource distribution's different, the challenges are different. And so maybe the verification visits need to be different. And so I really hope that we will see maybe a different subset of within, the gray book or whatever color is next, recognizing kind of those differences between being a rural trauma center and a non-rural trauma center.
That is a good point, Alicia. Thank you for making that, because we have grown, and, the rural, the Level 3, Level 4, rural, so that's a good point. So we don't want anybody to feel left out. Any other questions for Dr. Register? Okay, thank you, Alicia. Appreciate your report.
Thank you. Y'all have a good rest of your day.
All right, we'll move into the Georgia Committee for Trauma Excellence. Lynn Grant.
Good morning and happy Friday Eve. So as you can see, our subcommittees have been very, very busy. Our PI subcommittee, they are working on development of our comprehensive PI playbook. The initial steps are underway for that. They did send out a survey to all centers to identify what the trauma center needs for PI to help to create the playbook. The goal is to share tools and best practices such as the PI process, loop closure, and any tools for reporting and drill down analysis. So that is underway with that group. The pediatric subcommittee, they've been working with Dr. Vassy and the pediatric TMDs to develop a one-page pediatric transfer poster that will align with the adult version transfer poster that the TMD group has recently created. And a rough draft has been completed with this. They also are continuing to work on the pediatric transfer toolkit, and they've have assigned certain sections to each of the committee members for completion. And they are also continuing to collect the data for the EMS Safe Transport Project. The educational PowerPoint has been completed and approved and available for centers to use for education. And I believe that has been disseminated to some of the centers already to help educate on EMS Safe Transport. The registry subcommittee, the planning is underway for the ICD-10 education courses. Hopefully that will be sometime this fall, and there will be a basic and advanced course offered for the registrars. And as Dr. Walker just talked about, there is a core group that's evaluating alternatives to the V5 registry. 2 systems have been reviewed already, with 1 additional system pending. And obviously the goal is to select the most suitable software solution for the state, as she said. The education subcommittee, their main focus right now is increasing the number of trauma certified registered nurses in the state. And a lot of facilities have begun or continue to offer the review courses for this certification to help increase the number of nurses certified in that. They're very excited with the STN orientation modules that were approved last meeting, and that is nearing finalization of having the product to share with other designated or verified centers in the state. And they're just working on some language with the terms of use for that. They're also continuing to work closely with the Georgia Trauma Foundation to maximize the efforts in providing trauma education to rural areas in the state. They're focusing right now on the RTTDC courses throughout the small facilities. And for injury prevention, as you know, National Stop the Bleed Day is May 22nd. So there will be Stop the Bleed webinars on May 19th and May 21st. The webinar that was held in January, they had over 500 participants, which brings the total number of participants to over 8,500 since 2021, which I think is amazing. The Georgia State Safe Week, which is focused on firearm safety, is June 15th to 21st, and they are planning for that week. They've already have lots of educational materials available that centers can use and actually co-brand with their center's name and share with their communities for firearm safety. And they are focusing on expanding and sustaining the evidence-based fall prevention programming, such as bingo size and a matter of balance, to keep that fall prevention education available to all our trauma centers. And our next meeting is actually August the 21st. And that was all I have. Are there any questions?
Any questions for Lynn? Okay, great report. Great work, Lynn. Thank you very much.
Thank you.
Okay, we'll move into the Rehabilitation Committee report with Dr. Vox.
In attendance.
Oh, he couldn't make it.
Last minute conflict, so.
Okay, we'll move on then. All right, so we've already had the Trauma Administrators Committee report. So Dr. Dunn, we'll move into Trauma Systems Performance Committee.
Thank you. As the administrators, ESO is undergoing a lot of changes and a lot of additional trauma centers. So with the changes to their platform, that creates issues with downloading our trauma, our national, our statewide trauma data into the state's database. So the way in her group are work tirelessly database to try to develop patchworks and schemas and make sure that that data is appropriately mapped from ESO into the industry. That is a significant challenge, and that is not just a simple, hit a button and the data down. It requires patchworks and a lot of people. You would think it would be simple, but it's not. And that goes to the issue of trauma registries in general. As ESO becomes more and more challenging to work with, and their fees continue to increase, and individual hospitals being gobbled up by healthcare corporations. Healthcare corporations are now moving to try to develop their own trauma registries, which will become, I think, a risk for us in Georgia to maintain a statewide database for our trauma data. If we have 3 or 4 different registries out there right now, according to our trauma contracts, we're all required to be on ESO. But that is gonna be a constant threat, I think that we're gonna face for the years to come. We're gonna try to figure out a way or how they have a way to minimize the impact. Trying to get down those 3 different measures registers into the national, into the statewide database would be overwhelming, and we simply don't have staff to go. We don't want to take a step back. Because we're leading the country right now, a lot of things that we're doing, so we're gonna have to try to get out ahead of that, and try to, strategize on national threats and how we do the rest of those threats. The dashboard was has been a, idea, suggested by the ACS Systems Committee, and they initially, had a draft dashboard, and then we put it out of sleep because there were several other, more important issues at the top of our list that we need to deal with. We are now circling back to this trauma dashboard. We do have a preliminary dashboard for the board of the state, and, Gina Solomon, to try to pull our, the statewide database. And right now, that's out to the, assistant performance committee to review and see if it's the type of data that we want. Is that data we want to collect, and how will that be around our trauma system, in Georgia, and is that the right data? So the more to follow on that, once we have a rough draft of that dashboard, we'll send it to the committee, we're not quite there. And then lastly, I think it was probably 2 years ago now, that actually, suggested that the data, the assistant performance committee, take on the used to do our project. And that has been, a very, tough journey to accomplish the honestly. And so, and an offshoot of that, to find out how long does it take follow-up, we said in addition to rural Georgia, you get to the first hospital and then ultimately to the loved one's house, how much time did that take? Well, that is very, very difficult to identify and find. And so in the interim, Dr. Cassidy's hospital and my hospital did a pilot project between just our 2 centers. And we finally have some data, which I think is probably representative, of the state. It may not be representative in, the urban centers because it's the time to transfer so quick. But it may, like at least go through a brief overview of the data that we collected. It's still an evolution as we try to decide that and find it, but there is some interesting things that take out of that. Danny, can you bring it up? Okay, next slide. So just, actually say this slide, so Naomi Kirk today is actually an ER doc at Dr. Ashley shop, and she is doing, I think, grassroots or doctorate in Johns Hopkins. And so she wanted to take this project out. She was the end of this, to start this research project at Dr. Ashley shop, and then we jumped on, from another one to add more data, to their project. All right, so really what we're looking for is the time definitive care from the ditch to the level 1, does that time affect mortality? And inherently, common sense is that it would, but we've actually found some interesting data to address that point. Okay. Let me just go back. There's a lot of data out there about ditch to the first hospital, ditch to the roughly level 1, non-developed transportation. Transportation had a whole other degree or level of variability into the question. And so most papers have just dealt with a simple scene to the level of trauma center. And there they show clearly that time definitive care managed, right? So we wanted to see where it was from. When you add a transit center hospital there for community access, that's really our rural centers are doing. So let's just go back to the more short right now. We'll do next slide. Next slide. All right, this is our short diagram. This is where we started out. We initially had 6,000 $152 actually got in mind of all trauma patients that are registered for 2019. But when you look at it, and the first type one was how many of those patients were transferred. And that whittled it down to 2,400. And then we had a bunch of issues with either inaccurate data, no data, inability to tell if this is a POV transfer to the first hospital, which we excluded all those. And then we whittled that number down by 2/3, and then we got 813 patients that were before our data set. But then when we saw extreme outliers, we saw people at outside hospitals for 4 or 5 days. Well, that didn't make sense. So we removed those outliers, and then we're now down to 798 patients as our cohort. And we're going to go next time. I'm sorry, we can go back. There's opportunities that I think that we can work with all of us at the team about those trip reports and working with the paramedics about how to get accurate data. Some of those reports we had to remove because they either didn't have the right data or there was inaccurate data. And maybe we need to look at a better system rather than annual input. I don't know how we can do that. That's something we can talk about. Next slide. Okay, this is a little bit of a busy slide, but the average age of the patients that were transferred was about 55. The average ISS, which is a score trauma centers use, is 12 injury severity. And 11 is not that injured. It's like a hip fracture with a contusion or something. A little bit more than that. But, so we're not dealing with severely injured patients as a whole. There is a core group of injured patients that are in this data set, sure, but on average, the data set is not that big. And if you look over, our number one mechanism was falls. 46% of that was from falls, and that creates a problem in our data set because if you have that elderly person with a hip fracture at an outside hospital, they can stay there for days, and that may not affect their ultimate mortality, right? So we have to, and you'll see where that comes into play in our analysis. But that's one of the things that we had to take into account. Next slide. All right, so now we start looking at times. So if we're looking at just ambulance times, these are the two from the scene to the first hospital and from the first hospital to the second hospital. Dispatch, time on dispatch to arrival, how long you were there before you could, and then when did you leave. And I think most of these times were reasonable, at least if you look at it for ED1 transport. Those times, I think, relatively are reasonable times, given the rural studies that were in. About 43 minutes from the time that hospital, that ambulance is dispatched, till the time that they arrive at the outside hospital. So that's, I think that's really reasonable. You look at the first time for ED2, arrival at outside hospitals at the time of dispatch of the ambulance. That's a significant amount of time. That's about 3.5 hours. Now, you want to say, well, then that's the all outside hospital time before they made the decision to transfer. That's not necessarily true. That's the time the ambulance was dispatched. What we found is that those outside hospitals are calling to find an ambulance company that can transport their patient. Once the ambulance company, once they find somebody that will transport, and they actually have an ambulance, then they will dispatch that. So the outside hospital could be calling, could be making the determined transfer much earlier than 210 minutes. But this is the time that the ambulance is actually dispatched to the hospital. So we got to kind of tease out what's going on in that outside hospital. Unfortunately, we don't have the data in this data set to be able to answer that question. But that's where the bulk of the time is occurring in the time of definitive care. Is the time of that outside hospital. And so if you look at the top side, the top line, time of injury outside hospital, 82 minutes, or 55 minutes if you look at the mean. Median is probably more reasonable, but I think that's reasonable. An hour from the time the ambulance is dispatched, to the time they arrive on scene, they treat the patient, they leave, and then they transport to the first hospital. I think that's a reasonable number. If you go down to the well, let's go down to where it says in hours, the first bullet line. That's the total time to definitive care. From the time that the bubble is identified to begin the dish until they arrive to level 1 trauma. Anywhere from 6 to 6.5 hours. Oh my gosh. That's like the time, that's like golden hour on steroids. So, but that's the reality of what's happening in rural Georgia. And I think we've got to, what I hope to get from this is, what can we do differently to help decrease that time. I think I have that over in this broadcast. Next slide. So this is just an idea of time at the outside hospital is 70% of the time in definitive care, only 30% of the time is transport. So I don't think our issue is in EMS per se. There may be a finding an appropriate transport in the first hospital and the second hospital. But really, the bulk of the time is at the outside. This is just a more demographic outcome data. I would point your attention to the bottom two numbers on the left. Blood transfusion, 8.5%, patients dwelling with blood transfusion is about 8.5% of the data set, and our mortality rate is about 5%. Next slide. This is a really super busy slide, but suffice it to say, and I'll give you the spoiler over. We did not find time to definitive care as a risk factor for mortality in this study. And so then we thought, well, maybe we're looking at it differently because we need to look at this differently because half our patients weren't that injured, right? And so, of course, time to definitive care is not going to affect mortality. So we looked at a more severe population. Those people that had an injury severity score greater than X, or a portion of their injury severity score. Did they have severe head? Did they have severe chest? Did they have severe abdominal or extremity? None of that made a difference in time to definitive care. So then you go down, and even injury severity. So if you go down and you look at injury type, shock, and blood transfusion, those did make a difference. There was a difference in time to definitive care in those populations. People that had a penetrating injury, patients that received blood transfusion, or people that were shot. Our EMS colleagues were smart enough, or the system was smart enough to have a lower time to definitive care in those populations and in populations that didn't have those three criteria. So that's good. That means the system can identify critical patients and can get them there sooner than non-critical. So that's good. But this is univariate data. Now you got to go into another level of statistics where you control all the risk factors, right? So this can be confusing or misleading. So we went to another level of statistics. I am not a professor of statistics at all, so this is going to be the W version of statistics. All right, so we also look at complications, and this is interesting, not so much for time to definitive care, but for our data quality and our trauma. We knew that two people with two more hospital complications, which isn't rocket science. You have a more likely chance to die if you develop complications in your hospital. Okay, not rocket science, but this is the slide that triggered me to remember that for our especially our comorbidity. You know, hypertension, diabetes, stroke, whatever. For our registrars, we have to make sure that they are capturing that data for our patients, because that's a risk-adjusted factor for mortality. And I think based on our TICA report, you may not have to do it. We may need to look at it more closely through our TICA report. Next slide. And this is just an interesting slide. Actually, just go by a slide. This slide is so now let's start looking into our risk adjustment. We know from trauma that injury severity, your head injury or your neurologic status, as evidenced by your GCS, and your age. The older you are, the more likely you are to die. The worse your head injury is, the more likely you are to die, and the more severe injuries you have, the more likely to die. And then our model corroborated that. So we know that we have good data in our system. Those are all significant risk factors for mortality in our digital. Next. And then we also broke it down by various levels of ISS, moderate, severe, critical. Although if you're really super injured, you have a 19-fold increased chance of dying compared to people who are moderate or minimally, which is not a surprise. I think that the degree of risk was a little surprising. But all that data again makes sense. And this is the baseline. So if we look at time to definitive care,
the p-value was not less than 0.5, which means it's not a significant risk factor for mortality in our gas. And I explained why I think that is. We still have some more deep dive into that to be able to tease that out. But that answers the question, at least here in Georgia, the majority of our patients transferred from an outside hospital, time is not bad. So now we got to figure out which patients does it matter, right? Next slide. Next slide. All right, so this is where blood transfusion comes in. This is not the best way to look at it from a statistical model, but it opens up the door to, a potential issue. If you look at time to definitive care and blood transfusion, there is a significant correlation to that. Meaning, if you require blood transfusion, every minute of delay to transfer to definitive care increases your mortality, which is significant, right? The next slide. And next slide. Okay, so we looked at it and we control for all the various risk factors that control for mortality, and the blood transfusion was still a significant issue with time to definitive care. So we need to look at people who are hypotensive as well. But I think for our EMTs and for our outside hospitals, if you're giving this patient blood, every minute matters getting into the loved one. And maybe we prioritize those people. I suspect we're already prioritizing those people. I don't know that for sure, but that's one thing that we can communicate to our outside hospitals or our ambulance companies, that those people are the people that you really need to get in the loved ones. And that's all. Thanks. Yeah, I appreciate it. I'll be happy to take any questions.
That was a great presentation, Jim. Thank you. And Dr. Todd, any questions? I figured you would light up the screen with a commentary, but yeah.
No, I mean, I think that's fantastic work. It's kind of interesting that it didn't show much difference. The interesting is that time to definitive care, if you look at that confidence interval, is really, really tight, and you're right at 1. So, I mean, it just kind of makes you wonder, different sample, larger sample. I mean, I don't know. I just kind of wonder if there's anything there.
Right. So maybe something actually where
Yeah.
if you don't have enough patients,
Yeah.
at the building, but because the difference is small. So now we're working with Gina and her group and trying to do this at the state level. We could probably triple the number of representatives we have. And interestingly, when we first did this, only 15% of the PCRs of the ambulance trip reports for the first trip from scene to first hospital were in our trauma. 15%. With the help of the OMST office and looking through justice, they were able to give us a significant number. But the reality is, the local trauma center can't get access to the first trip reports for whatever reason. And I think that's a system issue that we're going to need to look at. Probably. Yes. Go ahead. No, go ahead. Keep it. With that. Yeah. Sure.
Yeah, just the other thing is kind of interesting is, I mean, your biggest point was the vast majority of time is time spent at the trauma center, which is kind of, yeah, that's what I mean, at the first location, which I mean, is kind of goes back to the basis of ATLS. You should never delay a transfer. And so it just seems like there may be massive educational opportunities to say, once you know, I mean, I can speak from our standpoint, Grady, when we have a pediatric patient under the age of 15, we're calling for transfer almost before they even come to the door, because we know we're not going to take care of them unless it's truly an emergent case. So just kind of make sure there's real opportunities for education at those outside facilities, saying, don't, we always talk about don't get the studies, et cetera, et cetera, et cetera. We often find that doesn't happen. So it just makes you wonder where the educational opportunities may lie on that front. So.
But I think there's a kind of platform, and I'm sure you see it as well, or at a grade. The vast majority of patients that we get from small medium hospital have been cancer. They've been worked out from head to toe, and some of that is understandable if a person comes in because they fell.
They think that they can handle it until the gas station shows that they have a huge head fee, then they realize they can have a chance. But there are those patients that have come in and they know from the get-go that they are not gonna keep that patient. And yet they run it through their gas scanner anyway, so that they can justify the need to transfer that patient. Honestly, all they need to say is, I don't feel comfortable taking care of this patient. I would like to transfer him to a trauma. We're all gonna say yes, but there's just a mentality, I think, from the lower level of the hospital, that they have to justify the reason for transplant. And I think that's what we should do.
Say, I will commend you if that's the way you answer the phone, but I will tell you that's not always the way the phone's answered. So from an education standpoint, I think you're right. If there's education out to the masses of, look, you need to tell these people in certain situations, you know, stabilize ship, don't get the imaging studies, so that's coming down sort of from the top down. That's helpful.
So just as a follow-up to that, Dr. Vassy may report on that as the leader of the Trauma Medical Directors Group. They are working on, and may have already sent it out, we'll get his report, but they've been working on a letter and a poster to put up, like the burn poster in these ERs, and a letter from the Trauma Medical Directors to say what he just said, that we want you to send it as soon as it overwhelms your capacity. You don't have to do all these extraneous tests. We're not going to yell at your, we've had a bad history, it's like accept and pay. You got to justify it, And so we need to change culture, and they are working on, I've seen the rough draft of sending that letter out to all the ER. So that's your point's well taken.
Just two last thoughts on that. I agree with you 100%. That's not always how it goes. And, certain states in certain regions, they'll have like automatic acceptance for certain criteria. So it's just something for us to think about at some point. Does that make sense for some of these populations? And then
Yeah, they really insisted that we have a doctor conversation and not do auto accept for trauma. We have an auto accept for our ER for non-activated patients, but they were hesitant to, they can't mandate it, but they were against us going for, auto accept for trauma. Because they wanted that doctor. I'm not sure why it matters if we're gonna say yes, and except that it allows us to give some education or some advice, how they can further stabilize that patient prior to transfer. That's what I would get.
And just the last thing I'd say is, we know at Grady that 39% of our transfers we take in are discharged from the trauma center. And so figure out how that plays in. I know we've talked a lot about teletrauma, but how do we do that so you can actually impact the availability of rigs? And fascinating data.
And then we don't want it to come out that time to definitive care doesn't matter. I think, because we've thought a lot about this. This was surprising when we looked at the data. Jim's done a great job of really driving this. He knows more about statistics than he's letting on. But anyway, he's done a very good job. But something's, when you look at seeing, it definitely is making a difference. But something's happening at those outside hospitals. So it's not like they don't get any treatment at all. They may be getting some blood, they may be getting intubated, they may get a chest tube. It's not like there's nothing happening, when so something is happening at the outside hospital. So the take home, at least on this small study, and again, it was 700 and something patients. So we're not ready to say time to definitive care doesn't matter. And I don't want people to go away and say, the commission says time doesn't matter. We can just take 18 hours to get that patient transferred. That is not true. That's not what we're saying. But with fast EMS times, seem relatively fast in rural Georgia, to get them to the outside hospital with some intervention, whatever that might be, for this patient population, which most of them, again, are not that injured. ISS of 11, you see how I'm building a lot of caveats here. If you have this, maybe time doesn't matter. Then 5 hours or 5.5 hours is probably reasonable. So it's not that time doesn't matter. It's like 5 hours in this patient population in this part of the state at our 2 trauma centers and regions seems to be appropriate. You see how, so we just have to keep all this in mind. But again, I think as we see numbers expand, and if we get the state data and look at state stuff, we can see, drill down, and I bet you will see, like we even in our small numbers have if you're getting blood, it seems to matter, which is intuitive. I think we'll see more time does matter depending on certain type interventions, you know. So it's a great study for discussion, but it doesn't answer all the questions.
One last question, I apologize, and you may have said this, Jim, but do we know that time at the outside facility, do we know how much that time was them waiting for transportation?
No, that's what
'Cause
we
that's-
can't answer with this data set.
And because I just kind of, it's interesting. I mean, I was on call the other night and accepted a transfer at about 1 a.m. and they showed up at 6:30.
Yeah.
And so it just makes you wonder how much of that time was them waiting for the availability of a rig to get that patient there.
It's anything, any transfer, I think. No, it's the ground.
We don't have data when they call me. And that's really the data for that's the data we don't have that.
Jay asked a question, I can't remember. Is this just ground or is this air? For, our transport, from the second hospital, I can't remember.
PCR, we had,
No, ground or helicopter.
yes, right, we had both types of PCR.
Okay, so it did include helicopter transport. Okay,
When you have a ground in, the first transport, so we had to kind of parse through that a little bit, but the vast majority of these were ground. There were a few areas, which kind of, in some ways, skews the data a little bit, right?
I had one question. Dr. Todd mentioned 39% rate of transfer and then discharge. That's an interesting number. I don't know where that come from. But in the shortage of EMS transports, I think that's something that would probably be interesting to look at to de-burden some of the EMS issues.
Yeah, and that's, Roxy Albright and the folks, other places have looked at it, and that's a relatively consistent number, that 30%. And to your point, what we're trying to do, just a proof of concept pilot is a little bit of teletrauma we're doing with a local Piedmont level 3 center and focusing on the big one, TBIs, facial fractures, ophthalmological injuries, and where they'll keep those patients with direct consultation. We'll have access to the patients and stuff like that, and have an automatic acceptance if they deteriorate. But to your point, we're just going to local initiative. It's probably easier, but I mean, I think Dennis and I've talked about this a lot, but you could imagine at some point in the future in the state, if you could build that out and build out what those models look like, you could divide the state up by where level ones own a geographic region, and you really partner with those smaller facilities and work with them to where they're comfortable keeping some of that. And that way, at least you're only using those rigs for the patients who really need to come to your facility.
We just completed study that looks at the results of the CT scanning control. So almost all the smaller facilities have a magnifying system for radiology report. And what we found is of the people that had the transfer that had outside film, they had those films reread by usually 25% of them were in. So you're getting transferred correctly that you don't have. And I don't know how you get away with that, but.
Kelly, do you have a question?
Well, I just wanted to make a statement. One of the things that I'm looking at the data, the amount of PCRs that couldn't be found was really concerning to us. But one thing I realized afterwards is this study was done within a year of us doing a major upgrade to our EMS data reporting platform, which could be why not able to find, or you were not able to find all the PCRs. And my thought was got done with your comment on redoing study maybe with all the trauma centers. After 2019, we have that 2019 year, this is that major update that we did with ambulance services. Probably have better results finding those PCRs, even if you stay with your 2 facilities. And let's get out of 2019, because 2021 was where we started getting better, getting all the data. That makes sense.
Sure, it makes total sense. This was just one part of the water study. So we actually looked at 2 different years, 19 and 21 or 22. I think it was 22, I'm not sure.
I think we did a COVID year just so we could, when we could do the next study, we could see if COVID affects it. Yeah, we did. Or maybe Or maybe we did COVID. I think we did it. Did we do pre and post or that second year? Yeah.
Regardless, we did it after, so we found the same problem. Only 50% of the first trip reports were in the registry, and we had the same difficulty. I don't know if there's a.
I think what she's talking about, what she's talking about is being in NEMSIS or GEMSIS, being in, not at the registry. That it's not there.
Right.
And so, but in GEMSIS, where we can go in the cloud and find it, those numbers did get better over time because people were loading it in the cloud. So we had the ability to go get it, which at first we didn't.
People that never had, from your shop, my shop, we had a similar problem getting those, and I don't know if it was a GIMSA connectivity issue but it would take us 15 minutes to find out if we could find one record before it said yes or no or here's the record. So when we gave it to you guys were able to find it much more quickly. So I think, I don't know, we could talk about that.
Yeah, let's do that. I think it would.
And I'd like to acknowledge you all, OMS&T in the office. I know you had some people working on this because we were calling every day with, I need 100 charts, I need this. And we couldn't have got that beautiful data if you all hadn't have committed the resources. So thank you for doing that. Okay.
Dr. Vassie has his hand raised.
Oh, thank you.
Comments.
Dr. Vassie?
Yeah, can you guys hear me?
Yeah, go ahead, Matt.
So I think I'm not terribly surprised that overall the numbers didn't show time to definitive care matters. And I agree with you, Dennis, that that's not the message that I get out of this. I think it identifies the challenge is there are two different populations. There are the people that need emergent care, and there are the people that fell from a ground level and have a hip fracture. That's oversimplification, but I think that it's such a common transfer mechanism that it waters down the ability of the data to predict how important time to definitive care is. You started to flesh that out when you looked at blood transfusions. But I wonder, I know when we accept a transfer based on the injuries that we know or the information we get from the referring facility, we will decide on an automatic activation level. And I wondered if you looked at this data based on those that arrived in transfer that were actually had a trauma team activation associated with that arrival, if that might be an indicator, because it may get to the higher level of injury and the blood transfusion and the intubated patient, airway compromised patients that we feel like data should eventually show time definitive care for those patients really matters. So I wonder if that's a possibility moving forward.
Sure, absolutely. We did not look at that. I don't believe we looked at activation level as one of the data points that we looked at. This came from the trauma registry, but as more as I think about it, there's a lot of people in the registry that were never activated. So I don't think we have that answer though, but that's a great idea.
While we have you, Matt, Jay asked about talking to the outside hospitals and medical staff about an easy acceptance. And I don't know if you'd signed on, but I told him your committee, TMD committee, was sending out a letter or was addressing that issue that when you think you need to transfer, we will be nice and accept the patient quickly. So could you give him an update on where you are with that?
Yeah, and Liz can kind of help me on the actual up to the minute update, but we have approved the poster. It's been branded and formatted and made to look really nice with the information we provided. Liz, can you give everybody an update on exactly where we are and actually getting those out? But I know we're pretty close if they hadn't gone out already.
I'm looking over at Gabby because I know when I was out at conferencing for the last 2 weeks, she was
They can
working
give
on
an
logistics.
update. We established a printer here in Athens, so they are working on getting those out. Those should go out probably by the end of this week to those rural level 3, level 4 centers that were identified. And we also emailed it to them. Oh, Crystal. And they'll-
Seeing brown and white here and displaying it in the room as we speak. Okay, that
It's
does
on
look
here.
good.
Yeah, so those are.
Yeah, they did a really good job about taking the information that we finally settled on and putting it there. I want to kind of build in a point that Rob made too. I feel like we have a responsibility to flesh out the difference between people that really need to get transported soon and folks that we might, by taking an extra couple of minutes, may avoid a transfer at all and just do an outpatient follow-up. So, and I think one of the things we can do as trauma directors is maybe expedite the process of either getting that isolated evaluation done of an X-ray, like for instance, maybe an ankle fracture or something that they don't have ortho, that might not need to be admitted, or teleophthalmology, for instance, which we'll talk a little bit about. But maybe the first question I ask when I have an isolated injury is not let me let my orthopedic surgeon look at the film and determine whether or not this needs to be transferred. Maybe the first question I ask is, if my orthopedic expert were to say this can be handled in the clinic, would this patient be able to be discharged from your emergency department? And if the answer to that is no, then I don't really need to ask my orthopedic surgeon. I can just accept that patient right on the spot and avoid that extra 15, 20, 30 minutes, maybe even longer, to get a hold of that expert. So that's just kind of a real-time thought that I had when we had that conversation, because Dr. Dunn, you mentioned it in going through the study. We don't really know how much time in the outside emergency department is spent coming to the decision to transfer, then getting acceptance to transfer, and then arranging transport or finding somebody that can actually be dispatched. And so that's the challenge. But maybe we can whittle down on at least some of that acceptance part, because it really doesn't matter. I mean, if somebody has an outpatient treated isolated fracture, but they can't safely be discharged from home, they need to come to the trauma center to be hooked into the right rehab, because those resources don't exist at a smaller hospital. So just a kind of a maybe kind of a minor point, but something I'll build into my communications as well.
I think, Matt, that it's interesting. That's something we've discussed a lot. I think one of the challenges, and we don't have an answer for it, but one of the challenges is then you sometimes transport those people to your facility and they don't have access to the resources in your facility because they're out of county or something like that. So now we've transferred them there. We still can't provide them the services upon discharge. I mean, it is tough for our underfunded or unfunded patients. And so I appreciate exactly what you're saying, but it gets even more challenging for us because now we've accepted someone, we can't provide those resources either. And now, I don't know. I mean, there's not a good answer. It's very tough with some of the underfunded or unfunded population, unfortunately.
Yeah, I'm sure you're just seeing the report, so, but I'm trying to get a poster. Was the plan just to send it in the level threes and level fours? I think that would be more helpful with critical access that are all rural.
Yeah, that's a good point. And one of the conversations we had at our last TMD meeting when we were finalizing the content, and we made some wording changes. Really, the target population for this is our level 4s and critical access non-designated facilities. There's not a hard line that you can draw at any level, but we kind of took out the transfer to the nearest level 1 or level 2 center, because there are some level 3 centers that are perfectly capable of handling high level injuries, and so we reworded that to transfer to the nearest appropriate level trauma center. But yeah, so I think in my mind, the target population is our level 4 centers and our non-designated critical access facilities.
Matt, are you going to send a letter with this too, to explaining what it is and not just have them have a poster show up and they don't know really what's going on? I think a letter would be important.
I included a letter in the poster and the email, so they should have an idea, and the attachments for when the poster goes out.
So who wrote the letter?
I did.
You did?
Approved by Liz.
Okay, so is everything in it, like the TMD there can, can you know like why we're doing this, or it's okay to transfer? Okay, I just didn't want this nice thing to show up and then not know what it's for.
So we partnered with. Our partners at the State Office of Rural Health help us do all these things with, they identified all 66 centers that it needed to go to, direct contact, so it could be mailed to that person and not sit in a mail room, I mean, we don't do anything half,
Good.
so. Yeah, it's going to the right place. They're getting the grommets on them like that, so they have and back double-sided tape, so there's no excuse not to hang it. There's every mechanism on there in the world to get it up and get it out there. So yeah, I think it's got the best success of succeeding that anything.
Good, okay.
And to the point that was raised earlier, one of the things that I want to put on the agenda for our next in-person meeting in August, and probably mention it on our GCLIP and TMD call next week, is all right, this is going out. So, we got to put our money where our mouth is when we're on the phone accepting these patients or talking to these facilities. Because this is what we want. I mean, we got to have it over triage. And we got to be able to accept those isolated injuries that need to come because they don't have the resources, even if we think it's a minor injury. And so that's definitely a point I'll make, and we'll talk about in our meetings.
Okay, Jim, anything else? All right, great work. And that'll conclude the Trauma System Performance Committee. So Matt, we'll just be a smooth transition right into your Trauma Medical Directors Committee report.
All right. Yeah. So that's kind of the big news. Is at long last we finalized the content and got the right folks involved to make it look really nice and kind of get it in that form where, as Liz said, there's no excuse to not display it. And hopefully those will be going out. So we're also working with the pediatric experts in our system and on our committee to come up with a concomitant comparable pediatric transfer decision scheme and for the same purpose. Then hopefully that will be ready to go out fairly soon as well. Lynn Grant was nice enough to allow me to sit in on the GCTE committee meeting this past week. And I'm hoping that in addition to the pediatric transfer toolkit that hopefully we'll pitch in and help with, that we can establish, ongoing collaborations. And she's going to be attending our meetings as well. One of the interesting conversations that we've had at our last couple of meetings is to Rob's point about isolated injuries that need specialist evaluation, but often can be discharged from the trauma center once they're transferred, are our isolated eye injuries. And so, these conversations, at least on a offline basis, have really been productive. There's actually we've identified through Dr. McKimmy's input and the things that they've been doing in Northwest Georgia to kind of cover for their ophthalmology shortage. There's actually a startup teleophthalmology service that is really fledgling, but has great potential to kind of help us out. And we're in our facility, we're investigating getting that up and going, because really our first I won't say low hanging fruit, or we could have accomplished it by now, but really our first goal with helping out our centers around the state with ophthalmology is to avoid those transfer and discharge, which really just are a lose-lose for the patient. They're out of their area. Now they're at a place 30, 45 hour and a half away from home and don't have a way to get back home, and they're being discharged. And it also ties up EMS, and it eats into that ditch to door that for that population of people that really matters for. So we're going to continue those conversations, and Dr. Zach Belest, who's a local ophthalmologist here in the Gainesville area, is the president-elect of the Georgia Society of Ophthalmology. Actually did a grand rounds for us on, helping us identify and triage eye injuries and eye screening a little more effectively. And we really got a lot out of that presentation. He's actually agreed to give that at our next in-person TMD meeting in August. So looking forward to that and furthering those conversations so that we can hopefully not tie up ambulances and have a lot of folks discharged from Brady's ER after an ophtho evaluation. But those are the things we got going on. Really appreciate everybody's help and getting some of these things across the finish line, and look forward to collaboration with GCTE moving forward.
Okay, any questions for Dr. Vassy? That was a really smooth transition right into our committee. I'm glad he tuned in a little early there. All right, I don't see any other questions, Matt. So thank you for that report, and thanks for getting out the poster. It really looks good. We're getting to see a real copy of it here in the room. And so let your committee know that we appreciate it. That's great work.
Thank you, sir.
All right, we'll move into the Georgia Trauma Foundation report. Dr. Bleacher.
Thank you. In February, the foundation hosted a trauma awareness day at the state capitol. 68 people attended, and 52 of those were for the first time. By all accounts and feedback, it was a successful day. The foundation awarded some legislators recognition for their contributions. We had 2 legislators awarded a Trauma Champions Award, and those were Senator Kate Kirkpatrick and Representative Lee Hawkins. Their offices were instrumental in constructing the resolutions that were read in the chambers. We also awarded Trauma Heroes to Senator Ben Watson and Representative Butch Paris for their support for trauma care legislation and funding. All of the legislators had relayed to us that they were very honored to get these awards. The people who attended worked the rope lines. The legislators who met with their constituents and discussed trauma, and also received appreciation for their support of trauma, said that they were very happy to be face to face with their constituents. And so overall, it was a very fruitful day. With regard to marketing, our engagement with Lens Marketing for medical reasons has also been moving forward with improving trauma awareness. And in March, Cheryl and I were through Lens's contacts, we were on a live radio show on WSB to discuss trauma care in the state, and also introduce the Georgia Trauma Foundation to the public. This show is pretty well attended. It typically has 25,000 listeners per Sunday afternoon, and Lens has also arranged for us to be on the show 2 more times this year. So that's improving some public awareness through that medium. Lens has also distributed some press releases, and I won't read all the places, but several local newspapers have received information from the press releases about the awards that were granted from the foundation this year. The electronic billboards around the state have also started to advertise the Georgia Trauma Foundation to improve awareness. So we're hopefully raising our profile in that regard. Next year, Lens will be focusing more on Atlanta as far as public awareness. The focus has been on smaller communities, not entirely, but places all around the state so that we get a wide reach. And then I just wanted to finally say that in 2 days, we're going to be having our major fundraiser for the year, the gala at the Georgia Aquarium. And that's why Cheryl's not here today, is we're in crunch time. But all indications are that it's going to be even better than last year's successful fundraiser with regard to ticket sales and sponsors and all those metrics. We're outdoing last year, so we're looking forward to it and hope to see everybody there. That concludes my report.
Just a quick question, you should know this from now. What is the mission statement of the foundation, or what is your? Yes, that's a question.
Yeah. The mission statement is investing in trauma care to save lives in Georgia. And the vision statement is, and I'm paraphrasing here, is that from injury prevention to recovery, providing the peace of mind that all Georgians have access to optimal trauma care regardless of where they live.
Okay, any other questions for Dr. Bleacher? Okay, thank you, John. Now we'll move into the Office of EMS and Trauma. Stacy Smith.
Hello, everybody. Try to make it quick. I know we're trying to crunch up on time. So our report's in the packet, but I'll hit some high points. I always want to shout out the success for the centers that have been designated. So Liberty Regional is a new level 4. So they've got their designation. The Doctors Hospital of Augusta received ACS verification and redesignated as for the state for level 2. Advent Health Redmond was also ACS verified, redesignated with the state as a level 3. And then Wellstar West Georgia was recently redesignated as level 4. So those are our current designations this quarter. Then I wanted to talk about some of our data through the Office of EMS and Trauma. So one update, we mentioned at the GCTE meeting, but just to overview, we get the file from ESO for our data to be downloaded. We sent this off on March 10th, but they have a leeway of 90 to 180 days to give that file to the centers so they can send us our data. So right now it's still not complete. So if they push it out to the 180 days, we might not get all of our stuff till September. So just know that it's not going to delay anything with our like deliverables or reports, because we understand if you can't send it to us, you can't send it to us. So we're waiting on that file to get pushed out. And it will include the 18 additional files that was required from 2024. And then the ESO users will install the update and push it back to ImageTrend. So we are aware of there's some delay with that. We would like to have it in June, but I don't know if that's going to happen. So the other things, we are still working with Grady they're doing the new ESO, and ESO continues to work with them to work with the registry and report writer. We don't have any go live dates with that, and we also haven't heard any sunset dates for the V5. A lot of centers have been asking that. So I don't know, Gina, have you heard any sunset date? Mm-hmm. Okay. So let's see. We have done some data QA sessions with level 2 center and center in region 9 that's working towards designation. Marie Probst and Gina are still working together to validate the QA data with them. We have 2025 annual facility ID numbers and EMS provider ID numbers were all sent to the new ESO. So it could be prepared for that system when it does launch. Our epidemiologist has received the 2024 data. So she'll be working on that to put out the trauma annual report. Does that go out in September? August. So that'll be released in August. Just to touch base, we've already kind of mentioned it with Liz. One of our challenges has been that the level 4 did not have ACS standards. We were happy to see that they were out for public comment. I thank Gina for her Word document that you put together. So we're gonna have a meeting, Georgia Trauma Commission, and then we'll meet, and then hopefully all the level 4 centers will join on the 28th. So we can go over these standards and see what we want to put back out to the survey. That's all I have for now.
Okay, very good. Any questions for Stacy? All right, thank you, Stacy. Anne Marie back there, I know, providing foundational support with the registry stuff. Okay, open up any new business that we hadn't covered. I know everybody's tired, but it's been a good day as far as a lot of discussion.
Dr. Ashley, I've got Kyle here. I'd like for some of us to stay around for just a few minutes to talk to him.
Okay.
To give him an overview of what we're trying to do.
Okay, I'm available, so. Can I get a motion to adjourn?
Absolutely.
All right. Approved. Thank you.